Good morning and good evening.
And good afternoon.
Dr. David,
Good afternoon, good morning.
good afternoon, good morning, and good everything.
Good everything. I like that.
Welcome in Biwudant and welcome in Egypt.
Thank you. We're very excited to be all together today.
Actually, we have a very nice start. We are over 180 attendees, and I hope and I'm sure we will enjoy your lecture. So I will be in the background just in case if you need anything. Dr. Abdurrahman knows how to bring me in.
Perfect.
It's your stage. Please, Dr. David, would you please introduce yourself?
Going in about 5 or 10 minutes.
I will do that.
Okay.
Okay. So, hello everybody. Good morning, good evening, good afternoon from Egypt. It's honor for me to do the live webinar with Dr. David Clarke. He's one of the best mentor for me for direct restorative dentistry. He taught me a lot of things to do, not only in dentistry, also how to manage a problem, how to look to the problem from different perspective that usually I used to look from another one. So we welcome him in this webinar, Dr. David. I don't know if you know that here in Egypt and Middle East, he's the first general dentist using a microscope in US. For how long, Dr. David? Like 25 years ago? 25?
Yeah, it was 25 years ago.
Yeah, so I was at like 10 years old when he started to use a dental microscope. so he introduced the dental microscope for general practitioner in US to look different, to look in different way, how to do veneers, how to do composite, other side of the endo. And he started to I think the AMID for 1995, the American Microscopic Academy for Enhanced Dentistry. Since when you started to do the Academy for Microscopic Dentistry?
I think that's been almost 20 years ago.
20 years ago. I actually attended one of these conferences maybe 4 years ago. I went to the AMIT in California. So he wanted the people to see the difference you have to see first. And I think since 2007, he started to struggle to have a new matrices. The BiClear came into his mind, and he started to use for himself first, and later on the company started to produce for us. So every time I go to the learning center, I think I learn different ways to do direct composites. It's completely different from the I used to do. It's an honor to be with you, Dr. David, and I'm pretty sure that everyone will like and will love to hear from you all the tricks that you have taught me, and also I will learn something new today. I'm sure.
I hope so.
Yeah.
Well, I think it's always a beautiful moment. Abdurrahman, I have learned some things from you. It's an honor for me to be a friend and a colleague with you. So what we're going to be doing today is we're going to be doing 2 or 3 different things. I'm going to be showing some slides of diastema closure. We're going to talk about it. We just have a short time together, so I just want to get everyone excited and teach you a few things. We're going to be doing a live peg lateral. We're going to be showing the different techniques that we use for what's called delayed wedging when we're doing a peg lateral. So the theme of the lecture is diastema closure.
Yes.
And then the other thing that we had an idea is we're going to have a contest and a prize. And so we're going to have people email questions, and then we'll look at those questions later. So Ali, do you want to tell them what the prize is?
Yeah, I think they already know. We posted in the Facebook, so the prize will be La Smile Weave from the BiClear. So this is like a direct smile design way if you want to do direct composite filler. Even if you want to do indirect ceramics, you want to know like arbitrary what you want to do, so you can use it. I have used it for implant also because I had a diastema and I want to know where exactly should I put my drill. So I use it in implantology also. So it's very good tools to have in your office. So we thank BioClear for this prize. And just to be noticed, you have to email. There is 2 emails will be showing at the end of the lecture, my email and my Dr. David Clarke email, and you just send the answer within 5 or 6 minutes. So we will pick the best answer.
Yeah, let's go ahead and get one. Sure. All right.
Okay, let's go. Can you share your screen, please, Dr. David? The presentation. Yeah.
I believe.
Yeah. Now yeah, we can go.
Okay. Now I don't see the screen. Can you see the screen?
Yes, I can see it. Yeah, it's already shared. Yeah.
Okay, yours is lagging. Okay. All right. So I'm going to. My screen is lagging, Ali. So if you want to tell me if there's a problem, I'm just going to go ahead and click through the slides. Okay.
Okay. What I see now is the first slide with the. Yeah. Yes. The first slide with the the BioClear Learning Center. So you can just click on, and I don't care about the live in the Facebook, because what you see in the Facebook, it depends when you open the streaming. So just like explain what you see in your main computer, not in the other
Perfect.
devices. Okay. Okay.
Go ahead and give it up, because now it gives me an idea. All right. So we're very excited. I'm showing the next. Screen, which is our faculty for the Learning Center. And we're very excited to welcome Dr. Abdulrahman to our family. And he will be building his Learning Center in Cairo. And when will you be teaching your first class, do you think, Abdulrahman?
Yeah, the plan was like in the summer, but after coronavirus, I don't know, maybe the next year. Yeah. Let's
so
hope
anyway,
yeah.
So we want to welcome Ali to our wonderful family. We're very excited, and we're looking forward to great things from the Learning Center in Cairo. I'm going to move to the next slide. So the next slide is showing a post-operative view of both posterior and anterior composites. And it sounds like someone's in your home, Ali.
Yeah. Just give me a minute. Just 1 second.
Yes, I love the kids. Oh, yeah. So what we're looking at on the top is a 10-year post-operative view of replacement of amalgams. And those are a combination of what are called Calla-Lilly or Clarke Class 1, and then cuspal overlays where we put these teeth into compression. These were not layered. These were injection
sorry for
molded.
that. So sorry guys for that. Yeah, I live in a family house, so a lot of kids. So
That's perfect.
Yeah.
All right. And then on the bottom, you can see that this is a 6-year post-operative view of Black Triangle case. And I think that the post-operative radiographs are the most beautiful part about the BioClear method and matrix, is because I've been using a microscope for so long, I was very committed to creating microscope precision. And so I'm happy to show these very long-term outcomes to see that monolithic injection molded composite is something very special. And
yeah, I like the term of microscopic precision. This is good term. Like precision has different ways, so microscopic is different. If you want to do it, you have to use a microscope.
Yeah, and I would not be here today talking to you if I did not have a microscope. It would not. These inventions would never have come to my brain if I was not using a microscope. And so that's why we're here. So I'm showing a few slides of my journey. A lot of you before BioClear, or some of you that do not have BioClear, if you were to do a composite, you would take a piece of flat mylar, and I'm showing it here, and then you would put in a wooden wedge and you would have a negative emergence profile. And the problem with that is it creates all kinds of problems aesthetically and functionally with what's called unfamiliar negative space. That contact, that's a point contact, is orthodontically unstable. It doesn't feel right. I had
so this is your case?
No, it's a case I did a long time ago before BioClear.
Oh.
Yeah.
Oh.
Yeah. Isn't it beautiful? I'm kidding. Now, it's not done. I still had some polishing to do, but you can see the terrible emergence profile that we have from flat mylar. And so this was a big frustration for me. And it's a reason that back in 2007, that's 13 years ago, we built BioClear. And so the problem with flat mylar and a traditional wedge is that it creates a process and an outcome that is not what our patients want. You know, it's funny, Allie, I thought this was okay when I got done because it had a nice margin. So
and you give yourself a prize. So.
I give myself a prize, yeah. So I want you to talk for just a minute, Allie, about the difference between a doctor-centered outcome and a patient-centered outcome. In my mind, it had a beautiful margin. You can see the margin is good and it didn't have an overhang. So I was happy. So why don't you talk a little bit about the difference between a doctor-centered outcome and a patient-centered outcome?
Yeah, I will actually talk about that because 5 minutes before the lecture, I got a comment for one of my friends in case that I posted on Facebook with the functional anatomy. So it was not done by myself. My colleague Amr, he did it in our office. So he just commented that there is no good anatomy, like he cannot see tertiary or like detailed anatomy in the posterior restoration. So he's just seeing from his perspective, his doctor-centered outcome. He wanted to see what he wants to have, like in the picture, but he's not seeing what the patient needs. The patient needs to have a functional restoration that's plaque resistance, that there is not easy to collect plaques, and also not easy to be curious again. So the patient only want functional and posterior and acceptable aesthetic and functional. So if the aesthetic is not functional for the patient in the anterior region, he will not accept that. Like if the patient have this kind of frustration, like you have done 20 years ago, he will come to you, no matter if the color is good, he will tell you that I got some foods between my teeth. So you have to solve this problem.
Yes.
So there's a difference. We have to look.
Go ahead.
Yeah, we have to look from the patient, what the patient needs actually, not what we need. And we have to meet in the middle between what we should do and what the patient needs.
Yes. And so the interesting thing is that BioClear started a new conversation. So patients are now feeling, the word in English is empowered. They are the boss now. When I was in dental school, I was the boss, but now the patient is saying, I want this and I want that. That is new. And so we have to listen to our patients. So one of the things that the next slide is to compare a postoperative radiograph of bonding, where the doctor felt like, well, I've got this black triangle closed, but it was uncomfortable to the patient. And then we're showing you the difference between bonding and BioClear. And so as patients are now going on the internet, and I've had patients from Egypt email me and say, I want to see a BioClear certified provider. So the patients are now becoming part of the equation. They are demanding BioClear restorations, or they're demanding other things like, I don't want to have my teeth cut. So we're going to start the quiz now, Allie. So
I lost the screen for the the presentation. It's not loading. So if Bilal can solve this problem, because I only can see you. I cannot see the presentation.
I can see everything from my side. Would we ask the audience if they can see the slide also? There is a nice lady with the with the cover over his eyes.
I can see the slide.
Yeah. So
Most probably it's something wrong with you, Abdurrahman.
Yeah. So what I will do is I think I will have to go and come back again. Okay. Because it's not okay. Okay.
All right. So everyone, I hope everyone is ready for the first most important part of the quiz to win the Smile Design wheel. And I'm going to show this now. So the Smile Design gauge is super helpful. It has a black contraster you place here for photography. And then we've selected the 5 most common mesial distal dimensions of the maxillary central incisor. Pretty much every tooth I have ever seen is somewhere between 8 millimeters wide and 10 millimeters wide. And so we build for facially generated Smile Design. We'll measure the central incisors and make some predictions about arch form. It also tells us the average length.
It's online, Dr. David. You can check it.
What's that?
I mean, the photo is on screen.
The photo's on the screen. Okay. So we're going to be talking about this case, and then you're going to be sending us your treatment plan. And this will be one of the most important questions. Thank you. This will be one of the most important questions to win the Smile Design gauge is to give a treatment plan and possible matrix selection for this case. So let's tell the story of this nice lady. This lady is the wife of an orthodontist. Okay? The lady is the wife of an orthodontist, and she went to another dentist, not to me, and her husband, the orthodontist, said, please close the space on the mesial of the 2-2. So I'm going to show you the treatment that was done on the mesial of the 2-2. Now, can you see the arrow on the screen? I'm circling the mesial of the 2-2. Can we see that?
Yeah, it's we can see that, I think. Yeah.
Is it coming up yet?
Yeah.
Okay. So this is the patient that you're going to treatment plan. So let's say that you have taken some training from Dr. Abdurrahman, and I'm sorry that I can't say your name with a good ad.
Yeah, no, you're doing well. Yes, it's good. Yeah, no, Abdurrahman is good.
I'm trying. I'm sorry that I don't. Yeah, I'm sorry that it sounds bad. So you're going to give the treatment plan here in a minute. So let's show the tooth. So if you take a look at what the doctor did, you can see that he closed the space. He did a diastema closure on the mesial of the 2-2. Can you see that?
Yeah.
Yes.
And he had a good adaptation for the composite cervically. But
right. So he was very happy with this doctor-centered outcome.
Yeah.
Remember, he is only doing the treatment that the husband of the lady wanted. The husband, remember, is the orthodontist who did the orthodontics. So this poor dentist did what he was told to do. And then the patient, as soon as he was finished, the patient said, I don't like it. And I want to ask everyone in the audience right now, what was her number one complaint about this diastema closure? Because he did what he was asked to do. He closed the space. So can we take can we have take some questions from the audience as to far as what?
They can write like in a minute, in a 25 seconds, just so you can write down what the patient was complaining of after she had this treatment. Just write down the comments.
Right. So we're not going to share any of those right now. Can we share them or not?
First answer is tooth looks disproportionate.
Who asked that question?
This is not a question. This is the answer of the question.
Right. But who was the doctor? What was the doctor's name?
Actually, I don't think I can pronounce his name very well. It's Shitlan.
Shitan. I don't know. He's not
Shitan
from
Gouda.
Egypt. He's
Shitan
not from
Gouda.
Egypt.
Well, I'll tell you what, Shitan, you are correct. The words that she used was, it's the wrong shape. So disproportionate is exactly right. This is not even a dentist. So here's the next question. If we wanted to truly transform this tooth, we need to change the emergence profile. So let's ask the next question of the audience. Where did this doctor change the emergence profile? Did he change it subgingival, equigingival, or supragingival? What did he do when he changed the emergence profile? Did he change it subgingival, equigingival, or supragingival? Let's see what people say.
So there's another question now, guys. So we have done with the first one.
Yes. And they answered it perfectly.
First answer is incisal, supragingival.
Yep. That's exactly right. Now, here's the next question. If we want to truly transform and get a perfect pink and white balance, where do we want to change the emergence profile? Supragingival, equigingival, or subgingival?
Yeah, we got an answer, subgingival.
Exactly. How do you change the emergence profile using direct composite subgingivally? Allie, what's the answer?
You have to inject it.
And we have to have BioClear. We
have
have
to have yeah.
We have to.
May I ask one question, Dr. David?
What's that?
Do you think this restoration was like this immediate post-operative, or after some time the gingiva just went more apically?
No, this was 6 weeks post-operative. This papilla was not going to fill. So let's back up, and now we're going to take a look at her case. This is where you're going to email to win the prize. You can email to me and also to Abdelrahman. That's my great accent.
You speak like French, so just stay with Ali.
French. Okay. I'm trying. So this is the email to win the prize. Okay. Does everyone have that email?
I think they had it, yeah.
Okay. So what we want to see is, in a case like this, that we can change the emergence profile, and we can change the emergence profile subgingivally. So this is a photograph of how we're able to push the soft tissue away from the tooth with a beautiful rubber dam, and we can change the emergence profile subgingivally with a margin that's better than gold and better than ceramic. It's 20 or 30 microns done ideally. So this is the miracle of when we took the mylar and we made this beautiful round shape, it made the mylar 3 times as strong. It's the miracle of what's called the second moment of inertia. You put a curvature in a material that's very delicate, it becomes strong. It was amazing. And it was an accident. I didn't know this. It was a happy accident, like penicillin. It is incredibly strong. And now with the new HD, which is 75 microns, we can dramatically reflect the soft tissue, just like packing cord. And it's a beautiful, healthy interface. And we have not seen any biologic width problems because the mylar respects the attachment. It does not sever the attachment. So we see very good soft tissue. So let's go back to the treatment plan. So I want everyone in the next 24 hours to come up with a treatment plan and email it to Abdelrahman and to me. And then this will be the most important part of winning the prize. So I want you to take a look at her treatment. Now, here's the interesting thing about this patient. she was so disappointed with the dentist that did normal bonding, she's not going to go to see that dentist for any more work. I'm going to have to charge her to take that bonding off and redo the treatment. So if you understand BioClear, or if you want to learn more about BioClear, I want you to treatment plan her with an ideal treatment to fix every aesthetic problem doing additive dentistry with BioClear. And I'm going to give you some photographs using the smile design gauge to give you some ideas about how you could correct her case. Now, I want people to ask a few questions as far as how you're going to do her case. I'm showing her midline, and one of the things that she specifically said was, I do not want any more orthodontics. That was rule number one. Now, this is patient-centered dentistry, and every day it's going to become more and more common in Egypt, just like it is in the United States. Patients are going to come in and they're going to say, I am the boss. So she said, no more orthodontics. She's had orthodontics 3 times. And she says, I don't want my teeth cut down very much. And I don't want porcelain veneers. I want BioClear. I read about BioClear. Give me a treatment plan. So you can take a look at there with the smile design gauge at 8.5. I'm giving you a little clue here about what you could potentially treatment plan in for this lady to give her an ideal outcome. She wants to have all of the black triangles eliminated. And she said, I understand there are other things you can do with BioClear. So she goes, why don't you tell me what else you can do besides the black triangles and redoing this diastema closure with BioClear? And then what I'll do is, after the contest is done, I'll give you the treatment plan with every single tooth, with every single thing that we presented to the patient to give her an ideal outcome. So once again, if we're going to change the emergence profile, we need to change it subgingivally. But instead of just treating one tooth, I know Abdulrahman, you would look at this case and you'd say, no, I need to do both teeth. I need to split the difference, put the midline here, and then treat the case comprehensively by injection overmolding a lot of teeth. And while you're at it, you could get rid of the negative space here. This is unfamiliar negative space there. Mm-hmm. And so there are a lot of different things that you could do for an ideal treatment plan for her. And she says, I want it perfect. So we will, this will take a little bit of time for you to put together a treatment plan. So let's ask some of the people in the audience, and Abdulrahman, any questions that you might have about about her case. Do we need to give you any more information before you come up with the treatment plan? So let's see what some of the people are asking.
Okay, guys, if you want to ask, so they have to send the answer after the lecture is done, right? Like,
right, but
for the
if
treatment
they have
plan.
any questions about anything about the patient that I'm supposed to tell them, hang on just a minute.
Okay, guys, if you want to ask a question, just
to help them make the treatment plan.
Somebody's asking about the occlusion. Do you have the photo, or do you have some pictures for the occlusion?
I do not, but her occlusion is fine. She has a very comfortable jaw. She doesn't have any occlusal problems.
Any facial midline photo?
This is it. This is all we have here. Let me go back. Yeah, and I don't want us to get too excited about some of the details. Just take a look at it, ideally with the information that you have. But here's her full face picture. Now, is this recorded? Will they be able to go back to this later?
Yeah, it's recorded, and we are not going to remove it.
All right, so they could review that. So here's a picture with her face. And remember, there's not a perfect answer to this. Don't get too stressed out. Just give us a good idea of the different things that you could do with injection overmolding, how many teeth, what areas, that kind of thing. All right. So I'm not going to back up because they have access to that. Is there any other questions from the doctors about?
Some doctors are asking about the radiographs, or any shift of function.
No, she's healthy. The bone is stable.
Okay, so then the only thing we can get from the radiograph, only the bone. So.
Yeah, she's very healthy. Anything else?
I think no. Since they can go back to the picture, so they have the smile design picture and also the profile, the side photo, so they can pick up the answer and send at the end of the lecture.
Yeah. Yes. So let's assume that she's periodontally healthy. The joints are stable, and the one thing that I told her was that we're not going to be able to create crazy white movie star teeth because she doesn't want the teeth prepped. So I cannot add a lot of volume. So I can make the color a little bit whiter, but it's not going to be like crazy Hollywood white. She understands that because we're going to be using Filtech Supreme Ultra, and I'm not going to be using any opacers. And she was happy with that, to have the teeth just a little bit whiter. Okay. Well, good. Abdul Rahman and I will look forward to your treatment plans for this nice lady. So let's talk about some of the problems that we see with composite, why the BioClear method is gaining popularity, and then we'll get started with this demonstration. We are scheduled for 45 minutes, and how are we doing on time? We're about 20 minutes in, is that right?
It's like 30 minutes then.
How many minutes left?
As long as you can. We're open.
Yeah. So when you look at the screen, we see a lot of the problems that we see with bonding, staining, flat emergence profile, point contacts, fracturing of the teeth. There are so many problems with composite that in the United States, unfortunately, there are a lot of dentists who say, you know what, composite doesn't work. I'm just going to do mostly crowns, which is amazing. But we see so many crowns in the United States because people expect the dentistry to last for 10 to 15 years. So we built the BioClear method on several pillars, but here's 5 of the most important pillars. Number 1, we have to disclose and remove biofilm because our tooth restoration interface, we don't call it a margin anymore. Our tooth restoration interface goes beyond the bevel. The most aesthetic tooth restoration interface is not at the bevel, it's past the bevel. So we have to remove biofilm and we have to disclose it. Ali, do you want to talk a little bit about when you first started thinking about the step 1 of the BioClear method, disclosing and blasting?
Yeah, I think the best way to convince anyone about the importance of this step, just to give him a biofilm disclosing agent and just to paint the tooth and wash it, and you can see how much biofilm you bonding to. So after that, you will disclose any tooth, like if you're doing only simple class 1. So yeah, even if you do cementation, you will disclose the tooth again. So
yes, it's everywhere. The next thing is modern cavity preparations, which is wonderful in the class 2. It's a very different cavity preparation. We're now actually seeing at least 8 or 9 dental schools in North America change away. This is an amazing story. I met a friend of Abdul Rahman who is coming to the dental school, and the dental school cavity preparation that he learned in Texas was an old-fashioned GV black cavity preparation. The cavity preparation that he learned in Egypt was actually more modern. And he said to me, he says, I feel like I've gone backwards in my journey when I came to the United States to Texas to learn this cavity prep, because this cavity prep is 100 years old. And I thought that was so amazing. So there are a lot of very modern countries that have not modernized the cavity preparation. They're still teaching a GV black cavity preparation. Did that surprise you, Abdul Rahman?
Yeah, I think also the same in Egypt. Just because of the internet, we got exposed to some of the new methods. So, and we have the more exposure to the Facebook than the people in the US. They don't use Facebook too much. So
that's amazing. So I think it's great. I mean, I think it's great that I tell people that Abdul Rahman and some of his friends in Egypt are doing some of the best dentistry in the world. And I think that's so exciting. That's exciting. The next thing we created was anatomic matrices that allow the composite to go around the tooth. With a metal matrix, you can't get the light through it. At a certain point, the metal matrix makes it very hard to do additive dentistry. And patients love additive dentistry versus subtractive dentistry. The next thing is we injection mold, and we love the 3M materials. They've done lots of testing on heating. It's very important to heat the materials. And so we have a partnership with 3M, and they've been very supportive. And 3M and Comet Burrs are committed to supporting Abdul Rahman at his learning center. And that's exciting. And the last thing is the Rockstar polish. This is a very patient-centered outcome. Patients love the way their teeth feel. It's amazing. And doctors focus sometimes on the wrong thing. And
regarding the polish, I did some diastema occlusion for one of my patient. He's a dentist, so I asked him, "What you feel?" He said that it feels like ceramics, like smooth, like ceramics, very smooth.
Because people feel their teeth all the time. We feel our teeth with our tongue to see if they're clean, and so it's a very important thing to patients. This is some of the studies that have been done to support the BioCare method. And these studies will all be available through Dr. Abdul Rahman. We'll give him a PowerPoint with all of the studies. And there are many strong studies now supporting the BioCare method. So we will give those to Abdul Rahman to disseminate.
Let me ask all the attendees, we will send one link with a Google form if they want to fill in with their contact details. We will send this to everybody on email or whatever method they want.
Yes. And so these, like I said, we'll send all of this. It's incredible science that's been done now with the support of 3M for the BioCare method. So we'll give everyone that information. Now, this is a little saying, before there can be true creation, there has to be absolute destruction. The problem, I think, and Abdul Rahman, you can add, is that when we try and fix the problems with composite, we want to fix just one little thing and then another little thing and another little thing.
استاذنك اعمل لنا الجوجل فورم اللي اتكلمنا عنه على في اللايف. عايزين جوجل فورم يكتب اسم الناس، الدكتور يكتب اسمه وتليفونه وايميله علشان نبعت له الداتا
بلال صوتك طالع. بلال صوتك طالع.
طيب sorry.
Oh, are we okay?
Yes, you can go now.
Okay, sorry. Okay. So the problem is, I want everyone right now to stop, and I want you to send some answers. This is a composite where the doctor tried to do everything the right way. He tried to put anatomy in, he layered it, he did nice beveled margins. And when you look at this failing composite, what is the answer? What is the problem here? So I want to hear what my doctors say. Why is this breaking? Why does it look like this? Let's hear what people say.
So you're just asking them, like, they have to think, is the problem from the composite? Is the problem from the way you place the composite? Yes.
Yeah, and there's a saying in the United States, what is wrong with this picture? What is the problem? What is wrong with the picture? Let's hear what people say.
I think we used amalgam cavity design to put composite.
Yes, that's okay. That's a big one. Yes. Most of the world still does that. Okay, what else? Let's hear another question. That's a good one.
Line of demarcation, biodegradation, cavity prep.
What else?
Not conservative, shrinkage cares, poor finishing, infiltrated margins, improper cavity design, not condensed, bonding, manipulation, no cusp reduction, shrinkage, ditching.
Okay, so let me have everyone stop for a minute. The thing that is wrong with this picture is everything. It's not, it's all those things and 50 other things all at the same time. And so we can't fix the shrinkage necessarily. We can't, we can't necessarily make it more conservative because the tooth was already broken. The problem is everything. So with the BioClear method and what Abdul Rahman will be teaching is a completely new approach where we leave the old world behind. We just walk away to do injection molded, infinity edge, compression based dentistry. So the answer is everything is wrong. Okay. And to make a true change, like I said, before there can be true creation, there must be absolute destruction. Let's leave the past behind, everything, and start new. And that's what I did with the BioClear method. And so we're having new conversations. We have a new language with BioClear, and we share it across the world. And so those are, if we're ever going to solve the problem, we have to start using the same language. So that's why we built the BioClear method. So I'm going to show a case where people think in the United States a composite is a bad material. So this is a patient who came to me, and she had these lower teeth had bonding done that was obviously not looking very good. So I'm going to make a little analogy to road construction. We're going to talk about road construction here, okay? So when we build roads, we have a bias that we think that concrete is better than asphalt. Now, Abdul Rahman, are most of the roads in Cairo and Egypt, are they asphalt or concrete?
Asphalt.
Asphalt?
The bad one, asphalt.
Asphalt. Okay. It's not necessarily bad though, okay? There was a time, especially here, where they think that concrete is better. So the concrete was supposed to be so great. So my comparison is between concrete and indirect and ceramics, and then composite and asphalt, right? So everyone thinks that asphalt is cheap, right? And when you look at asphalt, it's done by hand. They don't have the right temperatures. It doesn't have the right foundation, and it looks bad. It looks bad all the time. Now, I have a friend who builds asphalt for the airport. His asphalt is amazing. We're going to talk about him in a minute, but you can see that people think that asphalt is junk, right? It's temporary, it's patchwork, just like bonding is temporary and sort of junk after a while. And that's what people think. So there's a paradigm shift in road construction with new technology, engineering, and discipline. And my friend who builds roads today with beautiful asphalt, with the right temperature, with the right thicknesses, high temperature when you pour the asphalt, high density of the material, with the right pressure, it's amazing. And this asphalt can now be very, very permanent if you have a whole new rule. And so my thing that I tell people is, let's take our composite seriously as the real people laying asphalt today take their asphalt, and we can think of it in a new way. So let's take a look at this lady. We have a perfect storm of problems. Composite's hard to manage. You can't condense it. It has a poor finish that attracts biofilm. And sometimes we use it on our patients who don't have money and they don't take care of their teeth as well. So it's a problem. So here she is with all this bonding. But injection molded composite should be simple, safe, strong, smooth, sparkly, and even sexy, okay?
Like it depends on the country where you're from, okay?
All right, so I'm going to show her case. And so the first thing I'm going to do in a case like this is we're going to disclose. You can see how rough the teeth are. And one thing we do now is if we have enough attached gingiva, we'll actually exfoliate the soft tissue. We'll blast, and we're going to get bleeding. And you take a look at all this patchwork dentistry. You can see it on the radiograph. Whoops. You can see it on the radiograph. all of the patchwork, just like patchwork of asphalt, right? So the first thing that I'm going to do is I'm going to go ahead and blast. I have to blast, remove biofilm. When we use aluminum trihydroxide, it's very safe on the soft tissue. I can control the bleeding in 1 minute with ferric sulfate. We'll apply ferric sulfate. And then look at the rubber dam. Look how beautiful. This is like putting a 212 clamp on the teeth. So now I have the soft tissue pushed down. I have access. And now we're just going to do this one at a time. Injection mold every tooth. There's the Biofit HD. That's an A103 HD. And there's the first tooth. And we go to the next tooth and the next tooth. And so we're tweaking.
So usually, Dr. David, you have to finish tooth by tooth, so you have a reference. You don't.
Right.
Okay.
So we'd like to take every tooth to 80%, and then we go to the next tooth, because we don't want to lose our references. So thank you, Allie, for making sure we understood that. We don't take it to 100%, just 80%. And we'll go through the specifics on how to do this when we do the demonstration. Now, this was a case of a lady who didn't have a lot of money. I had to get the work done in a couple of hours. I think it's a nice case. I don't think it's perfect. I think that sometimes when we try to make things perfect, it makes it impossible. But here she is at 18-month follow-up, and the soft tissue looks good. She liked nice white teeth. It's not perfect. I don't want to show you a perfect case. I just want to show you everyday dentistry. But I want you to look at the difference between patchwork composite at 3 years old and BioClear at 18 months. And that is modern injection molded monolithic composite. It doesn't have, some things that doctors think that you need to put in a tooth like this, but you have to stop and think for a minute. If we don't do something very amazing for this lady, she's going to lose her teeth. Somebody's going to put crowns on these and do root canals, and she'll have no teeth. She is so happy with these teeth. And they're strong, and these could last for 20 years. The question is, how long can this last? That's the first question you should be asking. How long can this thing last? That's what patients care about. They care about longevity, because they know a crown can last 20 years, but it's very, very traumatic to the tooth to put crowns on these teeth. All right, so I'm going to stop here because I know people are looking at this case and saying, oh, those are crazy American white teeth. Let me tell you, in America, you have to make white teeth or you have to give their money back to them. They'll get mad. They'll bang on the door. I want my money back. I want white. Okay, so imagine if that was A3 or something. Okay, so I know people think, oh, David, yes, I opened her vertical dimension. I added 2 millimeters. That's one of the things we teach at the Learning Center is to, on many cases,
you have to listen to this. So our friend from Germany, Ricky, said, with the upcoming financial constraints on many people worldwide, the BioClear approach will be save a lot of these in the next 2 years. So coronavirus will push people to BioClear now.
Well, he's right. He's right. And so the thing is, I want us to feel like this can last as long as a crown. But the most important thing is not how long will the restoration last. Here's what you want to ask yourself. How long will the tooth last? That's more important. How long can I make the tooth last? That's a good thought. All right, so we're about ready to do a diastema closure. Let's go ahead and do that, Allie. And we'll get set up to do how we do diastema closure. And so if you want to talk to people just a little bit about maybe your and my relationship a little bit, how we met, your experience at the Learning Center, and then I'll get set up with the live demo, okay?
Okay.
Right.
Just when you do the live demo, just make sure that you will show to them the different color of the matrix so they can do the treatment plan for the case we posted in the presentation, okay?
Perfect.
So they can know, okay? So, so guys, So I have met Dr. David Clarke, I think 2015 in Italy, thanks to Pasquale Veneto, my friend from Italy. And this was the first BioClear's first Mortooth event in Benevento. And I was using the Matrix for like 2 years before that event. And this was my first hands-on course with him in during the conference. And after that, we met again in 2017 and 18, and this year in the Learning Center just to catch up with the like the full program and also finish my master track, so I can have the learning center in Cairo. So to do BioClear from my thinking that when you're changing the way you do anything, not only like composite, let's say root canal treatment, and you was taught to do tapering with the file ProTaper, for example, taperate, and you have been doing that for 10 years, and somebody telling you you don't have to do that, you have only to do 25 taper 4 or maybe less, or you don't have to clean too much, like widening the coronal surface. And nowadays they're doing that. And to changing the way you do dentistry, it needs a lot of effort. That's what happened with the BioClear. First, I like it the way to do the injection molding, but I did it only in the proximal, and I did layering for the rest of the tooth, and also for the anterior, I wasn't actually convinced I have to cover the whole tooth, and later on to remove what I want to remove and keep what I want to keep. So just try it first. The biofilm, use the biofilm disclosing agent. You can get this from any pharmacy, and you will see how many bacteria you left on the enamel surface that you're trying to bond to. And also try to do the modern cavity design. Imagine that the forces that the tooth will have when you do the restoration. So it will help you to think a little bit from engineering point of view, not just bonding point of view, because the tooth gets loaded like any normal tooth, so the tooth with the filling. So with the BioClear matrix is the matrix. The beauty of the matrix is not like how thick it is, how thin it is, like the design of the matrix that give you the chance not only to do the proximal, also to do the buccal lingual. If anyone of you have experience with the overlay, direct overlay, he will understand that when you do direct overlay with the normal sectional matrix, you only can do the proximal of the matrix, and you have to layer the buccal and the lingual cuspes by your hand. With the BioClear, you can do that in one shot, and the thing is smiler, so it gives you very laster polished surface. It has some difficulties for sure, but you have to train yourself like any techniques. But the thing is, once you got to know how to do it, you will be able to do it easily. I can see that.
Dr.
So
we have a couple of questions. They are kind of related to each other. This question is about the papilla in BioClear method. Is it a little bit constricted in the last case? In this case, in this one, the question is about the papilla. Is it constricted? Is it healthy to have this kind of emerging profile or emergence profile?
I think in this case, he didn't change the papilla because he didn't do any new emergence profile. He just injected the composite, but the people might think that he pushed the composite epically. He did the tooth more longer, so he did in this case, because I have the full picture of this case, he did a dual technique. So he increased the VOD of this patient by increasing by adding volume in the anterior and leaving the posterior apart, and after a couple of months the teeth get in contact. So there is no pushing in the tissue here. So there is some cases with some pushing, but in this case, no.
So the other question, which is almost related to the same outcome, the doctor is asking about why do most of BioClear cases look bulgy? I mean, why is it more bulky? Why does it have a bulge?
This is not, yeah, this one is bulgy, but I don't know why David actually showed us this particular case, but there is no solution for this case but to be bulgy, because she has no money, she cannot do ceramics, she needs only treatment for 1 day. So if he wants to end up with not bulgy tooth, he will remove a lot of the tooth structure that he has only a little. So the only solution that he can do here is to do a little bit more volume so he can stabilize the patient. So let's say this is a very long-term provisional, like for 10-15 years. I don't know how much it lasts. It might last for long until she can do the proper treatment, because if you want to have a good treatment, you need to do some orthodontic intrusion for the lower, because you can see the smile line is inverted, and you have to increase the VOD like by doing the full mouse from the upper and the lower. So not every case like a 100% case. You cannot do that for your full patient.
So, Dr. David, are you with us?
I don't want people to have that bias. So can we put my screen back up for just a minute?
Yes, you are in.
So I really appreciate the patient who asked me that question about the rounded or bulgy look of BioClear. When I have a patient come to me, a lot of these patients say, I don't want my teeth cut at all. I want a very, very white tooth, and I want a bigger tooth. So I'm going to that, but that's not necessarily what you have to do. I'm going to show you a beautiful case done by Dr. Charlie Regalado. He is a full faculty here at the Learning Center. And Dr. Abdul Rahman can tell you a little about Charlie later. He's an amazing guy. He's such a wonderful teacher. He has amazing hands. I want to show his case. And this is a little bit like a diastema closure. It's very large black triangles. So this is a woman who came to Dr. Regalado with massive black triangles. Now, this is a 3-year-old case, and Charlie was kind of afraid. And I want you to see how natural, where Charlie did not add very much volume at all. I want you to show you a patient who wanted a very natural look, who didn't want super white. And so this is a very normal BioClear case. You can see that she has devastating black triangles, and the teeth were stable. They had periodontal surgery. The periodontist asked Charlie to save her teeth, to make them aesthetically pleasing. The patient was very strong. She said no extractions, and her teeth were very strong. So here are the photos. Just show you very quickly. Here's a retracted view. He's trying in the matrices. These are the green matrices. These are DC201 matrices. We'll show you those matrices in a minute. You can see over here on the right side, it's a little bit constricting the papilla, so he made some adjustments here. There's the immediate post-op. Very, very thin. That composite's only on the facial. It's only about 200 microns thick. I think it's a very natural look. I think that when we show you the post-op at 2 years, you can see that you can make these very, very thin. So if you do not want to have a very white tooth, you want what a patient would say more natural. I think that these teeth are very natural looking. He didn't add near as much volume on this case as we sometimes see with maybe some of the cases that I do, because it seems like everyone that comes to see me wants crazy white teeth. And so I tend to make them a little bit bigger. There's the post-operative radiographs. Isn't that amazing? Look at the marginal adaptation. Charlie's an amazing guy, but he'll tell you, you can do this too with proper training. So there's the pre and post-operative radiographs. So let me back up and say, if you think that some of these BioClear cases look full, just ask the patient what they think. You can always bring the contour back, but if you do that, they won't be as white. So it's all about what the patient wants. If the patient wants white and they don't want their teeth cut, they are willing to have some fullness. And so, but I hope we answered that question. Okay, so are we ready to go to the demonstration now?
We are ready, but we have maybe one question if you want to answer it right now.
Well, ask it and we'll see if I answer it now or later.
Okay, the question is about the color stability of composite after injection molding. Will the composite stains?
The answer is the composite can be very color stable. Some people are not curing the composite completely. That's a problem. But if it's monolithic, it tends to not stain. The only problem that we sometimes see is in heavy smokers. I think in heavy smokers, the composite may not be quite as color stable. But I have, I'll show a 11-year post-operative view where the composite is the same color. Part of it depends on the underlying tooth. If the underlying tooth is getting darker, then the teeth over time will be a little bit less bright because the tooth gets darker. And we use Filtech Supreme Ultra, which is somewhat translucent. So it's depending on a couple of issues. So that's a great question. Let's go ahead and get started with the demo. Are we ready? Let's go ahead and get started. Are we ready?
Would you please close the mic of the microphone of the mobile phone? Yeah.
How are we? Is that good?
Yes.
So is the image up here now?
Yes.
Oh, perfect. So Ali wanted us to talk a little bit about the matrices. Now, I think people can still see me, right?
Do you want people to see you also?
For a minute.
Let me
just see my face. Are we ready? Can they see my face? It looks like they can see my face. Yep. Okay. All right. So here's how we make the choices. 01, 02, and 03. The 01 matrix is very broad, and it's great for the mesial of a central incisor. 02 are very curvy. That's good for the distal of a central incisor. And then the 03 is very straight matrix. It's good for lower incisors. And then each matrix can either come in pink or in green. And so the green has 1 millimeter of emergence profile. It's for diastema closure or large black triangles. And then the pink has only 0.5 millimeter, a more natural emergence profile. So that will help you to make your choices for matrix selection. Now we do have the black triangle kit, which is unique, and it's uses a different method for black triangles. So if you want to grab a black triangle kit, we can show them that also. So there are different ways to do the case. You can do it with original BioClear, or you could use the black triangle matrices, but we're going to be using original BioClear. All right, so let's ask everyone. We're going to be injection overmolding this peg lateral here on the 2-2. So what matrix would you use on this case? We've got on the distal, we have a large space there. Would we use a pink or a green matrix on the distal? Let me ask everybody. What do they say?
Still no answer?
Do we have any answers yet?
Not yet. Green.
Green?
Uh-huh.
Yep, we're going to use green. What about the mesial? What about the mesial?
What about the mesials?
What about the mesial?
Also green, pink, green, pink.
It could be either one. So let's try in the matrix to see. Let's try. I'm going to do a DC 202. I need a HD, DC 202 on the distal. It looks like I have non-HD here. Can I have HD DC 202? There it is. These are repeated. So I'm going to go ahead on, I'm going to try in the mesial first. So I'm going to use a DC 203 on the mesial to see if that has a good shape. So let's try the DC 203 on the mesial, and that has maybe a little bit too much curvature because I'm fighting the matrix. Can everyone see that? So I think that there's a little bit too much curvature on this. Now, if we go to an A103, which is the pink version of that, let's see what that looks like. So I'm going to get the A103 HD and see if that is a better fit. What do you think? Is that going to give us enough emergence profile? Yes or no? Ali, what do you think?
Yes, yes. This is. I think this will be enough for me to do the mesial for the big letter. Yeah, maybe trim the two. I don't know. This one is good. So if you did delayed wedging, this one will be good. Yeah.
Okay. So I'm gonna do it in between. I'm gonna get a DC 203.
So you can trim it.
And I'm going to trim it. That's exactly what Ali was thinking. I'm going to get a DC 203. I'm going to trim it, which is good for a child because they have a large papilla. So let me get a DC 203. And I'm going to go ahead, and we want to use the special biocular scissors, or they need to be non-serrated. So you can see the hip. You can see the hip in the matrix. So we typically want to cut a V cut here, and I like to cut it just like that, make sure the edges line up. This will change the emergence profile slightly, reduce the emergence profile, and make it somewhere between a green and a pink. So that's a pretty good V cut. I'll flatten that little spot right here. And now let's see if that changed the emergence profile enough to make so it's not overly curvaceous. So that's getting better. I'm going to trim it one more time. Make sure the edges line up. See, that would be a bad cut. Like that, V cut. And now it's somewhere between a green and a pink. And let's see how that looks. So we're going to go with this one no matter what.
Dr. David, I think you lost connection using the phone. I think the mobile phone is not connected.
Do we need to go out and come back in?
Yes, only from the mobile phone.
We see it here.
Do you see it, guys? Do you see it, Ali?
Do you see the model?
Well, I don't know. No, it's not moving. Yeah, now it's moving. Like it has some delay.
Yeah, would you please go out and go in again from using the mobile phone?
Sure.
Sorry for interruption. So would you like to comment about some questions which we already have?
Sure. Let's take advantage of our time and answer some questions.
I have read some notes about the stability after BioClear restoration due to the wide contact points. Some dentists said that they don't need any retainers. Did you come across with this note before?
Yeah, it's very interesting that a lot of orthodontists and periodontists are telling us that when we have a point contact that the tooth is very unstable. And so when we have this very broad contact that the BioClear matrix provides, it provides a lot of orthodontic stability. So you don't necessarily need a fixed retainer because that when you have a point contact, it's easy for them to crowd, but with a broad contact, they don't move. So we see less periodontal mobility, and we see much better orthodontic stability. That's a great question. Are we back up with the feed on the try-in?
Yes, I guess so. Let me check. Yes, it's okay.
All right, so let's stay on task. So what we're going to do is we've got the trim DC203, which at this point, Ali, it looks just pretty much like the A103 because I trimmed it a lot. So that tells you there's a real difference. And then I'm going to go ahead and show you the DC202. It's a little bit larger matrix. And let me have a 2x2. My fingers have some residue. I have my fingerprints on the matrix. Okay. And so that is the DC202 on the distal. And we're going to brace that in a minute. So I'm going to go ahead and do what's called delayed wedging on this case. So I'm going to want to make sure that my matrices are the same height so that I can manipulate them. So I'm going to trim this so they're all the same height. And that way I can pull the matrix this way to manipulate it. I hope that makes sense to everyone. So I like for these to be about the same height. Now, what we're going to do is, in a case like this, and 3M has actually validated this in their research, if I have no freshly cut dentin tubules, which I don't have here, I do not need to cure the adhesive independently. So we're going to pretend that we have acid etched this, rinsed and dried. And now we're going to bring in some Scotch Bond Universal, and we're just going to wet the gingival 1 millimeter on the distal. You can stabilize with your finger, and then the gingival 1 millimeter here. That's all we need to do. So this is called delayed wedging. So I'm going to go ahead. I'm going to air thin the adhesive, but I'm not going to cure yet. And now I'm going to bring in heated Filtech Flowable. This is Filtech Flowable, and it has a new syringe delivery that eliminates bubbles. And we're very happy with that change. I'm going to zoom my magnification up because I've got this sort of funny fingerprint here. I want to put down about 1 millimeter of flowable composite on the gingival, and that's all I want to do. People generally put too much flowable here, and then that's the wrong solution. Now remember, this is heated flowable. And now this is going to be very difficult on the mesial. This is a little bit more challenging. This is a good time to have a microscope. Yeah? Yes? As the feet, I'm back? Okay. Thank you. Now, what I'm going to do is I'm going to take a couple of instruments, or you can use your finger. I'm going to change the emergence profile here, and then Daly's going to come in and light cure this for me. So I'm going to change the emergence profile. I want to broaden the contact, but people tend to overdo this. Now, Dr. Konings will tell you from the Learning Center that people tend to overdo this. I just want to gently...
Sorry, Dr. David, it's a pity that we can't see the demonstration very well.
You can or cannot?
No, we cannot. I think the connection on the mobile phone is not that much nice. But as you explained, you put one layer of the bond, thin it, don't cure it, and then you inject some heated flowable composite, right?
Yes.
We are back now.
You're back now?
Yeah.
Okay, so are we okay now?
Yeah, yeah.
Okay, so let me review. We put some flowable here, about 1 millimeter on each side, and then we're going to go ahead and pull this over to broaden the contact. So the contact's about 3 millimeters tall. And now, without hitting me, Chris is going to come in and cure that. Go ahead.
So you stable the matrices in place, and your assistant is curing it, right?
Yes. And now I can let go. Okay. So now we have determined the emergence profile, and we've determined the emergence profile, and now we can go in and do delayed wedging. Now, we couldn't do a wedge before because there was no place to retain the matrix. So we're going to go ahead and we'll try a small diamond wedge. Let me actually try a medium. Now, the neat thing about the diamond wedges is when the diamond wedge is inserted, you can see that the window collapses like this and then opens up. So it's a lot less painful to the patient and provides a better three-dimensional anatomic adaptation.
Again, Dr. David, there is some lags.
Okay.
I don't know if it's a good idea to move the camera mobile toward the screen. Sorry, the camera from the laptop.
Should we go to the camera from the laptop?
Why not? Let's try. Now we have another view. Would you please just move it to be sure it's fast enough? Yeah, this one is nice. Please go ahead.
Oh, we just fixed our technology.
Okay.
we did what you told me to do yesterday.
So this is directly from the microscope?
Yes, it is.
Okay, that's good.
All right, we're back in business. So now we're going to go ahead and I'm going to bring in another diamond wedge from the distal. That's putting a lot of lateral pressure.
The diamond wedge again?
Yes. So the advantage of the diamond wedge is that we're able to create a lot of volume on the front of the wedge, and then it compresses and then opens up. And that allows a more 360-degree adaptation to the tooth. And I think let me try a large on the distal. Remember, you want to use the largest wedge that you can. So let's see here. Yeah, I actually got a large wedge in there. And now you can see that the tooth has moved just a little bit, and that's going to allow an even tighter contact. So now I'm going to go ahead and release the mylar just a little bit here at tick. And now we're ready for injection molding. So let's go ahead and let me have the adhesive. Now we're going to reapply the adhesive as a surfactant. We don't need to light cure this independently like we've already talked about. I'm just going to air thin this as a surfactant. And then we're going to put some of the Filtech Flowable. This is Filtech Supreme Flowable. It has the same color as the Filtech Supreme paste material. I want to make sure and create a nice wetting of the interface. We always want to have some back pressure to inject into. So now that I have a volume of flowable to inject into, I'm going to bring the paste in, and I'm going to start actually on this case more toward the lingual, even though we normally start in the facial, but there's so little resistance here in the lingual. I'm going to start here. And we have one more. Now, this is a difficult procedure today because it's a double-sided diastema closure. You can see that the pressure of the paste is pushing the flowable out to the facial. And now I'm just going to remove a little bit of the excess here along the gingival. And let me have a dry brush. And one more dry brush. So we're going to remove the excess composite just like we do for porcelain veneer. And I think I can do a little bit of adaptation with the paddle. Let me have the paddle, please. Is the movie coming along better now?
Yeah.
Oh, I'm so sorry that we had a problem, but I'm so happy that we figured out a better solution. So I'm just massaging this just a little bit here. I want to leave at least 2 millimeters of excess composite on the incisal because that composite on the incisal tends to be a little bit impure. And so we want to have some for cutback, just like when we mill a crown. Dry brush,
did you do something, Dr. David, because the video is stopped?
Do you want to grab Carissa and see? It looks like it's coming. Is it back now?
Yes.
Okay.
We have many questions about the same point. Would you please just mention again why didn't you cure the bond layer, the second bond layer?
That's perfect. We're going to answer that in just a minute here. Okay. So now what I'm going to do is I'm going to go ahead and I'll make a little bit. I can make one more slight adaptation of the mylar, of the bioclar matrix. If I want to get an even tighter contact, just a little bit. Now cure. We want to have a nice broad contact. So we're going right to the incisal first so I can let go of my instruments. Okay, come on out. And then final cure. So I'm going to cure 10 seconds here, 10 seconds on the incisal, and then we'll come around and cure. Can I get the filter? 10 seconds on the gingival lingual, and then 10 seconds on the incisal lingual. And then I like to re-cure it once I've finished. Okay, so let's pull the out. All right, so let's answer the question. Why did we, I'm going to let Abdul Rahman answer the question. In a case like this where we have no freshly cut dentin, this is additive, why were we able to not cure the adhesive, Abdul Rahman? Why is that?
Like for the second adhesive layer. So
go ahead.
Like if you're doing only enamel bonding, you don't want to cure the adhesive because first you don't want the adhesive. You don't want the adhesive actually. You just need the flowable. Just the adhesive maybe have a different surfactant from the flowable, so it makes easy for you to have more to have like different surface energy. But if you cure the adhesive, it might cure in a thicker thickness that will block the way for your composite to go through the matrix. So if you want to cure the adhesive, you have to make sure that you air thinned all the adhesive and you have to clean all the excess, which is not possible. So right. I suggest you to not cure the adhesive if you're doing only enamel.
And we will make sure that you get the copy of the study from 3M that says that you do not need to cure the adhesive separately if you're bonding to enamel. And it's the same. And then I would ask the doctor, that's a good question. When everyone does porcelain veneers, let's say you're doing a porcelain veneer on enamel, people don't cure the adhesive with the porcelain veneer. They just air thin the adhesive and put in the veneer cement or the flowable. So it's really it's no different than a porcelain veneer. All right. So let's go ahead and it's important when you take the matrix off that you reach under the contact. And this is a special Explorer. This is the Bioclar Explorer, Clarke Explorer. You need to have an Explorer that's very thick because the tip stays sharp. So we're going to release the matrix here. We're going to release the matrix here. And you want to release the matrix completely. All right, hemostat, please. Now, I want you to take a look at the integrity of the composite, We've got nice tight contacts with delayed wedging. And we have a Bard Parker, please. And if we have any little excess, we can just gently scuff that away with the Bard Parker. But if you look at the composite, it doesn't look like hand manipulated composite. It looks like porcelain. There we go. So let's go ahead and let's answer a couple of questions before we go on to the next phase.
Center, please.
Okay. So let's see what questions we have before we go on to the next phase.
Yes, we have some actually.
Oh, and let's interrupt here. Ali, what do you see right here that looks orange? What is that?
This is the excess of the adhesive, so it doesn't stay inside the cavity.
So what Ali is saying is the adhesive that started here got pushed all the way to the top. That's amazing. That's the power of injection molding. Okay, questions.
Number one, how can you control the shades when you are using two different materials?
I'll let Dr. Abdurrahman answer that one. That's a good question. That's a good question.
Okay.
Actually, I didn't get the question. How are you gonna use two different material? Like he used a flowable from different company?
No, he's talking about doing multicolor.
Yeah, he want to do two color in the same tooth, like to inject two color in the same tooth. You cannot do that. Like he want to the cervical with one color and to the other part of the teeth with different color.
Right.
It's quite tricky.
Yeah.
I don't know.
So we have a new conversation, and the new conversation is that the shape of BioClear, the smoothness of the BioClear, the longevity, I'll show you cases that can go 20 or 30 years, makes the patient so excited that the conversation about using multiple colors of composite is starting to go away. You're seeing a lot of focus on these new omnichromatic restorations that simply we're just using one composite. So the world is moving away from using two colors of composite. I'm not saying that you can't do it, but I always just use Filtech Supreme Ultra, and the patients love it. And you do see some polychromaticity because of the different thicknesses and the color of the tooth comes through. So I hope that at least kind of answers your question. So what I'm going to do now is I'm going to go through the shaping and then the polishing technique. So let's go ahead. And then Ali, I'm going to do you want to go ahead and give the narrative here and talk about what I'm doing while I'm doing it?
Yeah, I can do that. Okay. So first, Dr. David, he will start to remove the main excess. So when you do remove the incisal excess.
How close to the tooth am I going to cut?
Like, you mean incisally?
Yeah.
You have to leave a little bit for.
Right, 1 millimeter. Oh, yeah. And we always cut dry.
Dry, yes.
Because,
dry.
Except I was wet today, of course. In front of 1,000 people. It's supposed to be dry. And we cut dry because it's safer. It cuts faster because of the heat, but does not hurt the composite. So let's go ahead and cut through here.
And what do you say? What do you say about the people who can tell you that it might affect the matrix of the composite?
Say that again.
So some people saying that cutting the composite without any coolant is not good for the matrix of the composite.
I'm going to answer that question in a minute. So I'm cutting 1 millimeter from the future surface of the composite. And 1 millimeter in this area. Okay, can I get the Q finisher from Comet? So the next thing I'm going to show you is we have a burr block that Comet Burrs has made for us. And this is the burr block that they'll be using at the Learning Center in Cairo. And this is the Q finisher burr. It's a very interesting burr. It has a great shape for the lingual. It has it's cross cut, so it cuts quickly, but then once I'm finished, it polishes. So I'm going to put a little bit of lingual anatomy here with the Q finisher. You can see that it cuts rapidly, but also when you slow it down, it has a nice polished surface. So that's part of the burr kit. That's the Q finisher on the lingual. And I got this little bit of excess because I got excited. I didn't get my excess removed here, so we'll just cleave that away here. Make sure I don't cut my finger. There we go. Okay. All right. So let me have that coarse diamond burr. So I'm not going to be focusing too much on the lingual. I just really want to look at the facial. So let me just clean up that little bit of excess here. All right, so the next thing we're going to do is use the SoftFlex XT disc. Can I just use the medium? I'm kind of a baby. We'll start with this large, but I think I'm going to have to go to the small. I want to tip the disc about 10 or 15 degrees to the lingual because that's the normal wear pattern. So we'll tip the disc this way with the course facing away. And I'm going to match the incisal edge of the neighboring tooth, which is 1 millimeter shorter. So we come in quickly and mill this like so. And then let me have a small disc. Let me have the small. So we have two zones here. We have the BioClear zone that has a perfect finish. You want to leave that alone. And then we have the cut zone. So there's the BioClear zone that's basically perfect. We want to leave that so we don't get stained. And then this area is very easy to finish here. So I'm going to come in. I'll just finish the incisal edge. And we tip the disc to the lingual at about 10, 15 degrees. Now invert the disc like so. As the disc wears down, it becomes more of a polishing disc than a cutting disc. I'll round my incisal embrasure gently now that the disc has been softened and the edges are less aggressive. And then I'll go ahead and I'll gently round the mesioincisal embrasure. I'll leave that a little bit more square. And I'm not going to spend too much time here today. We just wanted to give you a taste of what's possible. So we could play a little bit more, but that's about all I want to do with the disc. If we want to create some nice gentle anatomy like we see here, we can just take the disc at a 45 and put a little bit of gentle anatomy here. That's all I want to do to create beautiful specular highlights. And that, you can play with that all day if you want, but we'll just create a little bit of anatomy there. I know everyone loves to do this. It's not very important to the patient. I know we love to do it. So we're just going to put a little bit of gentle mamelon groove, just a little hint here. Like I said, don't get crazy with this. Don't make this the focus. Dr. Konings will always tell you that people come to the Learning Center and they do a lot of this stuff, but then the restoration has big problems somewhere else. So let's not go crazy on a doctor-centered outcome. I'm just going to roll the embrasures in here so that each embrasure matches the neighboring tooth. So, like I said, we could do a little bit more here, but we just want to get moving. So that's the basic shape that I'm going to leave on this tooth. And if you want to thin the incisal edge, you can do that by rolling it in at about a 45 degree here and here. All right, so let's stop and take a couple of questions before we go to the Rockstar polish. Questions?
Yes, we have some questions. First one, when you move the matrix, will this cause any air bubbles? Before curing, I mean.
Oh, that's a great question. Now we've got Dr. Konings, who's not here today, but he's live, and he may be able to answer that question. So I'll ask him and see if he can email me the answer. But the bottom line is, when the composite is heated, it has basically the modulus is 0, and it's like a fluid. So when we move the matrix, we do not see any significant bubbles occurring. Now you see a couple of air bubbles that I somehow got in here. No, actually, those are just particles. So the answer is no. Don't worry about moving the matrix and getting air bubbles. If you're using Filtech Supreme Ultra, the viscosity is so low, we've never had a problem. So that's a good question, though.
Another question is when not to use wedges.
We don't use wedges if there's a naturally occurring contact. Like if I was doing a black triangle, I don't need a wedge. Sometimes if there's just no place to keep the wedge, we have to do delayed wedging like we did here. We put down 1 millimeter to make a home for the wedge, right? So that's delayed wedging. So when do I not use a wedge? We don't use a wedge on the anterior if there's a natural contact between the teeth, like on a normal class 3 or a black triangle. Allie, did I explain that okay? Where's Abdurrahman?
Let me put him in again.
Okay, so yeah, I lost you for a while.
Did you hear the question?
No, I lost you for a while.
Repeat the question, please.
Is it possible to not to use wedges, just to depend on the hip, the first hip layer to stabilize?
Yeah.
No, you cannot.
Probably almost never. I hate to say never, but that's dangerous. And I'll tell you what, delayed wedging is fun. It's fun. Allie, is it fun?
Yeah. If you lost the contact, you need to separate the teeth to compensate the thickness of the macros. However, for my little experience with the anterior teeth, if you lost the contact a little bit, not wide space, the teeth go mesially, so you will get the contact later on, but not like open space, like the floss is not tightening.
Right. Yeah. On a diastema, we would rather have you do delayed wedging because a good contact is very important to the patient. Yep. Okay. Let's go ahead and go to the Rockstar polish. So the next thing we're going to do is to get some magic mix up here. Now, do we have magic mix in Egypt? Do we have that there?
No, not yet.
Okay.
Send some.
All right. So what we're going to do is we're going to get a disposable cup.
Yeah, don't forget to answer about the dry finishing because the people asked about that.
Dry finishing on the disc?
Yeah, with the high. Yeah, no, the high speed and also the disc because people saying that it might affect the composite. So.
Oh yeah, we want to use the disc dry.
And also the burr.
Yeah, the burr. As long as the assistant's blowing a little bit of air like this, it's fine. Remember, composite is a very good insulator. So we don't generate very much heat if you just blow some air. We don't want to get things wet because then we lose visual information.
And we have a nice question also here asking about a very big cavities. Injecting, will it cause any shrinkage?
That's a question we get all the time. Now, the composite, the research tells us the composite is going to shrink no matter what we do. so if we cut a modern cavity preparation where the composite goes around the tooth rather than in the tooth, we can actually maximize the C factor. It actually helps us because it just shrinks like this. And once we cut a modern cavity preparation, if we do we put the tooth into compression, and we will send the studies to everyone showing that with the Clarke preps, the polymerization shrinkage is no longer a problem because the C factor is so low. So the question isn't, is shrinkage a problem? The question really is, what is your C factor? What is your cavity shape? And if you have more of a composite than the tooth, it will shrink toward the tooth. And that's what the research will send out to folks. So that's a good question, but it's now an old question if we're doing a modern cavity preparation. So in the class 2, which we'll talk about another time, we can mitigate some of the polymerization shrinkage problems with Filtech 1 and Filtech Book Fill Flow, but the cavity prep is the most important thing. All right, let's go ahead and we're going to go over how we do the Rockstar polish. Now, clinically, what Daly will do is she'll put some of the magic mix. Go ahead and put a little bit more right here, Daly. My dental assistant will put the magic mix actually on the rubber dam here in the vestibule because I want to get a certain volume of that and then come back and forth like a reservoir. Perfect. So I'll grab some of this. This is a disposable cup. We're going to run this at about medium speed. And the beautiful thing is you can take the magic mix and take it subgingivally. Now we're going to operate this at low to medium speed, and we're going to get new particles every 5 seconds or so. So
for how long?
Not eating the tooth. Hello?
For how long you should do that? Like 5 minutes, like 2 minutes?
A minute. That's it. Okay, suction, please. If you've taken the time with the disc, you don't need the magic mix for too long. Now, we're going to be having hang on, I'll wait till I get done with this. So this is now what we call the patina finish. Can everyone see that? What we're looking at are omnidirectional scratches. Now, Ali, can you see that the scratches are not going the same direction, but they're omnidirectional? Mm-hmm. That's what you want to see from the magic mix.
I want to ask you, can you tell the people what the ingredient of the magic mix like? Because some people ask it about, this is very good material. I have used it for like a year now, but the microns of the aluminum oxide is 2 thickness, I think, or I'm not sure.
Well, it's magic. That's the ingredient.
Okay.
Seriously.
Yeah.
It has large particles of aluminum oxide that are probably 200 microns in size. They're huge. And then very, very fine aluminum oxide that helps to give it the pre-polish. So it acts in 2 different ways. And then it has a material that binds it all together so that it stays on the tooth. So we used to use it made it by hand, like in the kitchen. It didn't work as well because the binder helps to keep it on the tooth. All right.
Okay.
So now we're going to go to the Rockstar polisher. And so this is diamond impregnated. And these are multi-use. You can use these 10 or 20 times. And we're going to start with this. I like to start it on the side. And we're going to go dry. And now come in here so people can see the air's coming there. There you go. So this will generate some heat, but we like it to go dry first because it does a very rapid polishing. You can see some of the deep scratches here. So I'm going to keep working on those deep scratches, but my dental assistant needs to be blowing air on the tooth. And now you can see that the deep scratches are just about gone. Can you see that? So I'll come in here and go dry for just a minute. I know everybody's noticing that I got a couple of bubbles down here. So I hope everybody feels good that Dr. Clarke had a little problem today. Oh, well, okay. All over the whole world, yeah. So, okay. So now we're going to go ahead and go wet. Now I'm putting about 3 pounds of pressure on the polisher. Good and dry. And if we want to get some more specular highlights, we can come in here and use the side of the cup to create a little mamelon groove here and here if you wanted to do that. But we're just basically showing the polish. So let's go ahead and water. What? I just wanted to show the polish there. That's what we're after, okay? So, questions. Here's my incisal edge. Like I said, I would have thinned it out just a little. I would have thinned this out a little bit more based on the occlusion. So once we adjusted the occlusion, we would take more on the lingual, but the facial surfaces is lined up pretty nicely. Clinically, I would not thin the incisal out until the rubber dam came off and I checked the occlusion. Because in a case like this, let's say we check the occlusion now, and I'll use my Q finisher. Once you start adjusting the occlusion, you're going to want a certain incisal edge thickness for strength. So, for example, if I'm adjusting the occlusion now, and I come in like this, I'm going to need that incisal fullness. So now all of a sudden, if the bite is here, that incisal edge doesn't look so thick anymore, does it? So if the occlusion was there, now this is the minimum thickness. We'll talk about the minimum thickness. But Allie, what is the minimum thickness for composite on an incisal edge buccolingually? What does it need to be?
You need like 1.52 millimeters?
Yeah, 2 millimeters thick buccolingually. Yeah, the thickness needs to be 2 millimeters. Yeah, so we're at about 2 millimeters. So that's an incisal edge that's pretty much unbreakable.
So how much time you need to do big lateral for a patient? Like half an hour?
Today I can do it in half an hour. Yeah.
Oh my God.
But I would if I were starting with BioClear, I'd give it an hour, maybe hour and a half. Have fun. Yeah,
it takes me more than a half an hour.
Okay. I know guys that can do it in half an hour, but it just depends on the guy, right? If it depends on the case. But I would like to spend an hour, sure.
Yeah, but the result is good. I have problem with the RS polisher. I destroy the polisher for 4 or 5 cases. Maybe I still do too much pressure. I have to work out with how much pounds I have to push.
Maybe it's too many pounds. Yeah.
Yeah. So
because I'm not having, they're not breaking for me. So we'll work on that. Okay. So I want to go ahead and show some cases, and then we're going to answer the questions at the end. How is that? Is that okay?
Okay.
Okay, but we got some notes. Somebody's asking about finishing of the proximal area, and I think it's a good time to emphasize about the polishability of the result.
Yeah, the only place that we're going to the only thing that we're going to do on the interproximal. What I would take, this is the BioClear, this is the 3M strip. I'll take this on the gingival margin only. And we'll take and pull that through like that. And then use the fine. That's it. We're not going to do any polishing on the interproximal. That's what the matrix did for me. So
and there's some studies showing that curing against milers is the best.
It is the best surface you can have with composite. Yeah. So let's take a look at the interproximal here. Let's see how we did.
Yeah, it's a nice trick.
Yeah, but don't try it at home.
Don't try it. Please don't extract the tooth. Yeah.
Don't try it in live demos.
So I'm not going to, I didn't clean up the lingual here, but you can see the interproximal. Take a look at the mylar there.
Oh, this is nice.
And that's that broad contact that you get that's so beautifully stable. And this is why we don't get stain with BioClear. The #1 composite complaint from patients is usually stain. Well, that surface is the best surface in the world to eliminate stain. So thanks for having me show the interproximal. Okay. Do we want to answer another question before we go to the presentation?
Many questions about wedging and trimming, if you just want to wrap up about wedging and trimming.
To review the wedging, what we do first is, let me have another, can I get another peg lateral tooth or not? Do you have another one? Yeah, I think so. So as far as wedging goes, we want to put, and when we're doing delayed wedging on a peg lateral, we want to put the flowable composite down about 1 millimeter on either side, cure that while we're putting the matrices over, and then we put the wedges in. So when we don't have any support or home for the wedge, that's when we do delayed wedging. But
so the point is to create a hip where the wedge will act.
Yes. So in a case like this, we would, let me just put this in one more time. Let's just do the distal here. So if we were doing this case, what I would do is, because this is a question that always comes up, so I'm glad someone asked it. So if I am going to do a wedge on where there's no home or no hip, first thing we would do is I would get, once my matrix is seated, we're going to use the DC202. That's the green matrix. Let's just say we're just going to focus on the distal. Well, let me go ahead and repeat it. I would go ahead and let me have a little bit of adhesive, please. So we're going to create the hip. And Allie, how tall should the hip be approximately, would you think?
Like it should be not above the starting of the contact area. So perfect. I don't know how many millimeters, but it should be enough, just enough.
Just enough, yep. So I'm going to go ahead and put down just enough, like Allie said, and I'm holding the matrix here, which is very helpful. I'm going to put down about 1 millimeter, but not to the contact. That's a good way of describing it, Allie. So you taught me something today. Thank you, Allie. The composite should not reach the contact area because then you won't be able to make any good changes in emergence profile. So that is below the contact. Can you see that? Okay, let's go ahead and cure.
So now we have a place where we can put the wedge for separation.
So that's the hip. Now the matrix is also stabilized, which is nice. And let's go ahead and use the large wedge. Once again, the nice thing about the diamond wedge is it's hollow underneath. It causes less pain for the patient. It has room for the papilla. And then the aperture collapses and goes between the teeth like that. Okay. So then we would go ahead and do the delayed wedging. Like that. And now the tooth has moved, so I can release the mylar a little bit and then injection mold the rest. So I hope that answers the wedging question.
Yes, you did. Thank you.
Okay.
So we can go for the cases now?
Yes, please. So let's get the screen back up here. All right, is the presentation up?
Yes.
Yes.
So I want everyone to take a deep breath. Okay.
Actually, I just want to thank Dr. Greg. He's answering many questions in the comments.
Oh, which Greg is that? Dr. Greg?
Yeah,
Greg.
from Germany. Yeah. Yeah, from Germany. Yes. He's our friend.
Very well.
Yeah, he is our guy. He is a BioClear wizard. Greg, it's good to have you online. I want everyone to take a deep breath. If you were this patient or this patient was your sister, how happy would you be? How happy would you be to know that the tooth was not cut, that you have a 0 chance of needing a root canal later? This is a life-changing thing, and it came with almost 0 biologic cost. Isn't that beautiful? And you all can do this. And like Ali said, you're going to have problems, and you have to pick yourself up off the floor and do it again. And every day you get better. Abdul Rahman, was your first case as beautiful as this one?
No.
No.
Honestly.
Neither was mine. Okay. So
I have one comment which is in place actually.
Yes.
Somebody's asking about the proper isolation during the preparation. I mean, when you put the matrix, I think the anatomy of the matrix make it very suitable for isolation.
Oh, yeah. You talking about using a rubber dam?
Mm-hmm.
Yeah, the rubber dam does, and I know Ali's does, Abdul Rahman teaches classes on the rubber dam. The rubber dam actually helps to push the matrix against the tooth. It helps to stop excess. A beautiful rubber dam is so helpful, especially for black triangles. So yeah, if you're serious about BioClear, if you want to be a serious BioClear provider, you need to think seriously about doing beautiful rubber dams, especially in the anterior. Well, I use them for every time, but thank you. Yes. And you know what's funny? A lot of dentists in the United States don't use rubber dams. So it's something that we all need to think about. So I just want to show this very quickly. We used to have direct bonding, and we've seen some of the problems with direct bonding. We have the chance for it to have lower cost or lower physiologic cost. The problems is it's hard to do. It tends to not last very well, and patients don't have much of a value for it. We have indirect ceramics that are strong. They can last, but the problem is, for me, the physiologic cost is very high for crowns. We know that 15 or 20% of every crown will need a root canal later. We know that we have to take away about 76% of the tooth to do a crown. So here's what's happening, folks. Patients are coming into my office and saying, I don't want a crown. I had a crown done, it needed a root canal or whatever. I mean, crowns are okay, but patients are starting to have a negative attitude about crowns and tooth reduction now, and especially now that we have BioClear that's offering something that can be very strong and beautiful like a crown with almost no physiologic cost. So the new third modality is BioClear. It is the BioClear method, and it has lower physiologic cost and many of the advantages of a crown. And here's what's interesting. A lot of our BioClear doctors are now, because patients are appreciating the value, a lot of our doctors are charging the same fee for BioClear as they do for a crown. I know that's may sound crazy to people, but you have to work, and it's a beautiful restoration. So you don't need to think, you don't want to compare BioClear to bonding, because that's not a good comparison for patients. When you talk to patients, you say, well, I can do a porcelain veneer or I can do BioClear. And in my office, it depends, but the BioClear might be 20% less than the crown, but that's about it. So don't think that you have to have this as a low fee procedure, because the patients are thinking of it as a third option. There's bonding, there's indirect, and now there's BioClear. So That's a conversation that lots of folks have. So we're going to talk about treating fractured and worn incisors with injection overmolding, that's IOM, and restoring incisal edges. So one of the things that people don't trust about composite is incisal edges. So this is a case of a patient who had treatment done in the normal way that we see on Facebook and we see in a lot of places in Europe. They did these cavity preparations where they have kind of a sharp bevel. This patient went through braces, orthodontics, wanted to have his incisal edges lengthened. So they did a putty matrix. They did with flat mylar, and they built the teeth. And here's the problem is that 5 years after the direct bonding done by hand, even though they spent a lot of time and they put 5 layers in, it's deteriorating and now it's broken. So now patient came into my office 5 years after all that work, and it was expensive. I mean, they went through a lot of work to do the whole normal layering technique, and now his tooth is broken. And so I had a conversation with the patient and I said, I can do BioClear, and I absolutely guarantee that you're not going to have any fractures for at least 5 years on the incisal. So I want to compare retreating normal layered composite that we did in the traditional way with the putty stent to the dynamics of injection overmolding. So this patient had 4 teeth done with traditional bonding, done by a very good dentist who charged actually a high fee. It looked good for a while, but then it broke, like a lot of times happens with hand manipulated composite. So there's the disclosing solution. There's the radius bevel, and this is a really interesting burr by Comet in the burr block. This has it's not quite a needle point on it, but it has a very nice shape for smaller areas. So that's one of the burrs in the Comet burr kit. We're going to make a radius bevel, and Abdul Rahman can talk to you a little bit more about the sizes of some of these tooth shapes. So it's a little bit beyond our lecture today. These are, let's see if anybody knows what matrix this is. What matrix do you think I used here? Anybody want to guess? Pink or green?
Pink.
Yes, because there's no need for a lot of emergence profile. So it's a pink. And I used the O3 matrix. That's the small matrix because the lateral incisor was pretty small. So that was the A1.
You use A1 103 for an upper tooth.
Yep, for a lateral. Yep, because it's such a small tooth. So there is my original shape. We're going to cover the whole tooth. We're going to do additive dentistry. There's the magic mix. Here's the Rockstar polisher. And there's the comparison between injection overmolding with a monolithic shape and bonding with a margin. Now, the tooth is a little bit thicker. So for this patient, I said, I'm going to do BioClear. I want you to see how you like this tooth. He went home. He came back later, and I'll tell you what he said. And 3 weeks later, he says, this tooth feels so much stronger and so much better than my other teeth. He says, I like the thickness of the incisal edge. It gives me confidence. Now, we'll post his video on YouTube where he talks about how much he loves his BioClear tooth. So once I had to pass the test, right? I had to show him that BioClear was amazing because he went to an amazing dentist before that did amazing layering, and 5 years later, it was falling apart. So I had to prove to him that it was different. The BioClear was not like bonding and not like a crown. And so he said, hey, I like it. Let's do the other 3 teeth. And so here we are. You can see there's more fullness on the 2-1. And then we're going to go ahead, and he says, the BioClear feels more substantial. Let's do the other 3 teeth. So we went ahead and did the proper radius bevel. But before I do that, I want to show you the thinness of these incisal edges. This incisal edge is about 1 millimeter thick. His incisal edge here is about 2 millimeters thick. And it's very difficult to break a 2 millimeter monolithic incisal edge. You can see his vertical stops here and here on enamel. And then the rest of this composite is basically in compression. So there's the disclosing. And what matrix did I use here, Allie?
BioClear matrix.
Yeah, which one? Which one?
It's like a 101, like for the mesial 101. Yeah.
No, I
No,
used
you trimmed the for the mesial.
No.
I think you trimmed the one.
I did it. Nope, that's a 360
201.
veneer. Nope, those are
Oh,
360
okay.
veneer.
Oh, okay. Okay.
So this is also not in Egypt. Send some.
Okay, send some. Okay. So it's can you see it on the video here, the 360 veneer?
That's one.
Yeah. So you could use an A101 here, certainly, and trim it, right? So that could certainly be an A101. All right. So let's continue. And so here's the next tooth with the at about 80%. And then once we go to 80%, we'll go to the next tooth. You can see here that we've added some volume. And we're going to bring that back in a little bit later when we polish all the teeth together. And there's the final case. He absolutely loves his teeth. He has 100% confidence that he's not going to break them. And to him, strength and cost and not cutting of the teeth were the most important things. And so that is a very different approach than layering.
I think he didn't change the color. Which color you used here?
That's B1.
Yeah, it looks good. I think his teeth more like A2, but B1 looks good in the picture. So
yeah, well, it blends with the natural tooth. And remember, he's a little bit dehydrated here, but so that's the shape of the teeth. And so once again, when we finish with these restorations, how thick does the incisal edge need to be buccolingually? Let me ask everybody. How thick should the incisal edge be buccolingually? How many millimeters?
So Bilal, he can tell us.
I'm waiting for an answer. How many millimeters buccolingually should the composite be to restore an incisal edge with composite?
I think people commenting, but Bilal is not here. Bilal, are you here?
Oh, okay. He must be sleeping. Okay.
Yeah.
All right.
No, he's.
All right.
You know.
So
okay.
So let's back up a little bit and talk about some of the principles that Dr. Richard Price tells us about composite. Number one, the more you manipulate the composite, the worse it is. Number two, you cannot overcure the composite, but you have to be careful about heating up the soft tissue. So when I do a case like this, I will go in and cure the composite a second time after I've finished the disking. Composite resin adapts better warm than cold. We know this. Flowable adapts better than the paste. That's why we like to put the flowable in first and then bring in the paste. Layering should be minimized. It is slower, has a higher risk of gaps and seams. And so in my practice, I just don't layer at all in the anterior, only for depth of cure in the posterior. If you have an air bubble trapped in the middle of the composite, it actually doesn't hurt the composite. We don't like it, but it actually does not actually weaken the composite. Injection molding shows great promise to increase our adaptation and to minimize seams and voids. Having an infinity edge is so helpful for aesthetics and to do additive dentistry. But a lot of the old thinking is, it's flash, it's bad, it's going to fall off. So the answer is we have to do what to have an infinity edge, Abdul Rahman? Where did we start today? We have to do what to prepare the infinity edge?
Say again?
If we're going to have an infinity edge, what's the first thing we do with BioClear to allow the composite to go onto enamel that we didn't cut?
So we have to open the buccal-lingual impressor. So you have to have a saucer-shaped cavity from the proximal. We have to have a saucer-shaped cavity,
right.
Saucer-shaped proximal surface.
Past the bevel, what do we have to do? I'll answer my own question. We have to close and blast.
Oh yes. You have to clean the infinity edge. Yes, sorry.
Yes, that's okay. That's all right. So, and now, Abdurrahman was just talking about the shape of the inside and the outside of the prep have a profound effect on adaptation. So I just wanted to back up and have one of the leading experts in resins talk about some of the work that he's done previous to BioClear and now doing studies on BioClear that really confirm what we're doing. And we know that composite is 4 times stronger in compression than tension. So if we want to have a failure with our composite, this is 8 different kinds of composites. We need to put the composite into compression and have no gaps and try to never layer it. If strength is your goal, then injection molding will satisfy those strength issues. So let's go back to the question. Here he was before with thin incisal edges. Here he is with more robust incisal edges. And this patient is a heavy bruxer. He is a heavy bruxer. So how thick should the incisal edge be buccolingually? Did anyone answer that?
A lot of people, a lot of people did 2 millimeters. Yes.
Okay, 2 millimeters. There you go. We need to be 2 millimeters buccolingually, even though you can bevel the incisal on the lingual and facial to make it feel a little bit thinner, but it's 2 millimeters just past the tip of the incisal edge. And then how much incisal gingival clearance do we need to wrap an incisal edge? Incisal gingivally, how much thickness of composite do we need?
Like you mean from the facial surface?
No, from gingival to incisal.
Mm-hmm.
What's the thickness of the composite? How much clearance do we need?
If I got the questions, there is no minimum. We can add as much as you can.
No. But what's the minimum thickness if we're going to cover the incisal edge?
Mm-hmm.
It has to be 2 millimeters thick buccolingually this way.
Mm-hmm.
How thick does it have to be incisal gingivally?
I don't get the questions. I know.
It has to be 1.5 to 2 millimeters thick incisal gingivally.
Yeah, you mean incisal third. Yeah, the incisal third. So yes. Okay.
So we have to have 1.5 to 2 millimeters.
It's the same for the crown preparation. The same for ceramics.
Basically, yeah. And so the problem is people haven't used basic engineering principles for composite. We don't have enough rules. So these are rules that we live by: 2 millimeters thick buccolingually, and then 1.5 to 2 millimeters thick incisal gingivally. And if we ensconce the entire tooth and put the tooth into compression, Dr. Regalado and I have done hundreds and hundreds of incisal edges, and they just don't break. Composite in compression, when it's monolithic, is incredibly strong. So there's a real contrast between sort of hand layering with margins and then injection molding, doing additive dentistry. So we are getting really late on time. I'm going to skip some of the rules. Ali can show these later. I want to show a couple of long-term diastema closure cases so that we can, so people can see what these things look like. One of the things that's a problem when a lot of people do lectures about bonding, they don't really show long-term outcomes. So let me go back here just a little bit, and I want to show you some of the cases.
We have an interesting comment from Dr. David Carroll.
Oh, David Carroll. Hey, how's the weather in Florida, man? Probably nicer than here.
I suppose you should see the comment on the screen now. He's commenting about the phonetics.
All right, David Carroll. I need my glasses.
Oh, let me read it. The
Here they are.
Let me read it.
Oh, this is great. So David Carroll, thank you, David. David is a prosthodontist. David is one of our visiting instructors, and he has a wealth of information. He posts quite a bit. So if you get a chance, make sure and read some of David Carroll's posts. So David Carroll notes, the thickness has generally not been an issue with phonetics. Remember that your lingual anatomy will be generally dictated by your occlusion and excursions. So your added thickness is generally to the facial. And so we see very little problem with additive dentistry. Think about all the porcelain veneers, the no prep porcelain veneers that people do. And a lot of those done well, people do okay with that. So adding a little bit of volume on the facial, and we're talking about sometimes only 500 microns, is not disruptive. And I think that people have to do it. You need to do 20 cases and have patients come back and say, hey, this feels okay. Or they might have you pull the incisal third in just a little, but then they say, I want strength. So thank you, David, for that. Thank you, David, for that comment. Let's take a look at a long-term peg lateral. So here's a peg lateral that looks a lot like the one that we did today. There are the matrices that we used, and I used the green matrices. And Ali, what matrix do you think I used here?
For the mesial, it's 101. For the distal, 102. 202,
Yeah,
sorry.
202 on the distal. I wouldn't use an 01 on the mesial. It's too big. So on the mesial, I'd use an 03 probably, DC 203.
Yes, maybe.
Yeah, the 01 is big. So there's my hips. And then let's ask everyone in the audience. I've light cured these. I pulled the matrix over. I light cured these. What's the next thing we do? What's the next thing we do right now?
Wedging.
Who said that?
Me.
You were not supposed to. They were supposed to look at the
I need the wheel.
Okay. We would do delayed wedging, and then we would pull the mylar over in injection mold. Yes. Okay. So I used the DC 202 on the mesial, and there's the mediate post-op. And here it is.
8 different kinds of composites.
Here's 3 years later. Here's 3-year post-op. Here's a 5-year post-op. Here is a 7-year post-op. Here is a 8-year. Here is a 10-year. And there's the 11-year post-op. So it's interesting. I was actually talking to John Coyce, who is a phenomenal teacher, and I sat down with John, and he's very interested in monolithic composite. He understands that in compression, that composite can be quite a powerful tool now. And so when I was talking to Dr. Coyce, I had this interesting conversation. I said, John, when I look at the 11-year post-op, of course, the patient loves it, and that's the most important thing. But I said, when I showed this photograph to the patient, and I compare her canine tooth, which looks like a perfect match to the lateral, versus her central incisor that has that gray translucency, guess which tooth the patient likes best, the canine or the central incisor? Let's see what people think. What tooth looks, not the BioClear tooth, forget the BioClear tooth, the canine or the central incisor? Which tooth do you think the patient likes better as far as color? Let's see what the doctors think that the patient likes.
Centrals, canine.
So most of both are canine.
Yeah.
Yep. The patient loves her canine. She says, I don't like the grayness on the incisal edge. And I said, you know what's funny? I said, when I showed this to John, he said, you know, almost nobody likes gray incisal edges. And then I said, John, I'm going to quote you. And then he says, let me soften that quote. John Coyce says, not everyone likes a gray incisal edge. So
again, it's the patient-centric treatment.
Yeah, it's a patient-centered outcome. And if you were to sample the color on the incisal edge right here, this is 3 shades darker on the incisal edge than it is in the middle of the tooth. Why is this tooth exhibiting some translucency and some polychromaticity, even though it's just one color? How come? Why? Someone tell me. This is 3 shades darker here on the incisal than it is right there, but it's all 1 shade of composite. So what's going on?
Let me see. Hall effect. Reflection.
This is just Filtech Supreme Ultra B1 body shade. Why does it look 3 shades darker and more translucent here than in the middle of the tooth? I didn't layer. All one color. Why does it look so much like the canine?
Different thickness.
Who said that?
Dr. Ghada Gur, I guess.
Yada Gur, smartest doctor in town. That's exactly right. The incisal edge at 2 millimeters, and then the middle of the tooth is about 4 or 5 millimeters. So we get a very nice translucency that patients like. Patients love the look of the BioClear tooth because it's frankly is softer than porcelain. And the advantage to BioClear is that transition between the tooth and the natural cervical is the best because it gets so thin. With a crown or veneer, that's a hard thing to match. The gingival half is easy with BioClear. And patients really look at the gingival. We're dentists, we're crazy. We just stare at the incisal edge all day like crazy people. Patients look at different things. They look further away. They look at the shape. They look at the color of the gums. They look at the match between the BioClear restoration and the root of the tooth, which is amazing. So we need to, and Dr. Ali has a great slide of a pirate or something, and he says, looking with patient eyes, right?
Jack Sparrow.
Jack Sparrow, yeah. So we have a new conversation that's beautiful, and it's about our patients and listening to our patients a lot more. And what most of my patients are telling me is that they love the feel and the look of this new type of restoration. So I want to challenge everybody to have an open mind and think about all the beautiful things that we can do by not cutting the tooth, by not hurting the pulp. We're not going to change the biomechanics of the tooth with additive dentistry. People have not studied the biomechanics of teeth when they cut on them. It changes the biomechanics. We get stress corrosion and things break 10 years later. We're not changing nature very much, which is a good thing. We're just strengthening it carefully. So we're going to be doing studies and loading these teeth in an Instron to show that these injection overmolded teeth are very fracture resistant, not just the composite, but the tooth restoration interface. Hey, let's show one more case. So here's my patient before and after. When you back up and look at the patient in a socially acceptable distance, she loves her teeth. This is, 11 years later. I want to show another case. This is an article that I wrote about identical twins. So these are identical twins that came into my practice. They're not quite identical, are they? So they have undersized teeth, and these are the teeth that this case that we do in our advanced class. I want to ask the audience, what is the patient doing with their tongue, and why do you think their tongue is doing that? Let's see what everybody says. What are they doing with the tongue, and why are they doing it?
Tongue thrust.
That's what everybody thinks they're doing. Let's see what else they have to say. Let's see what David Carroll has to say. Let's see what else other people say. Why are they putting their tongue there? They do not have a tongue thrust.
Facing the front teeth.
You want to hide the negative space.
Who said that?
Who said what?
Not me.
Who said hide the negative space?
Let me check.
This was me. I did it.
You emailed him to get the prize? Okay. You can't have the prize. Okay.
Yeah.
Okay. They're softening the negative space because the contrast between pink and white versus black and white is much less. So they know that when they have their photos taken, if they put their tongue behind their teeth, it looks less bad. Isn't that amazing? And so here we go. There's the view preoperatively. And let's go ahead and have the ideal treatment plan. You need to email the ideal treatment plan for these girls right now. You have 1 minute. Tell me.
Full arch Emax crowns.
What's that for? Emax crowns? Perfect. You win. So,
ideal treatment plan for the dentist.
Let's have you guess what the treatment plan is that I did for these girls. How many teeth did I do? How many surfaces? What would be the ideal treatment plan to try and keep the case limited, but to get an ideal result? So you're going to have to email that answer in right now, because we're going to watch the timing on this. Make sure that we have the timing on this. You have to email the treatment plan now, not later, to win the prize. So you have 1 minute to email the treatment plan for the twins. Now,
so this case will be the case for the contest, not the one in the first.
No, both. We'll give them a total score.
Okay.
This is the second case for the contest.
Okay.
So you have 45 seconds to tell me which teeth and what surfaces, because we're going to time it. You can't send it in after we tell you the answer, okay?
I should have written the email address in a faulty way.
So it comes like, yeah, okay. I'm sure someone will find some sort of hack for this, right? I'm sure. Okay. But we know that everyone that's a friend of Allie's is honest and good, right?
Yes.
Yes. That's the law. Okay. You have 10 more seconds to give me the treatment plan. You got to email it right now. Just say how many teeth, what surfaces. And remember, you want to do as little as you can to stay less invasive, but we want to get an ideal result. Okay, we'll show the teeth again. How many teeth, what surfaces? Okay, you're out of time. What's the time? What's the time? Mark it down, mark the time down for me, please. And then your emails have to be sent right now. Okay, so here's the treatment plan. We're going to be using pretty much all of the diastema closure matrices, DC 201, 202, 203. Here's the DC 202 that we used on the distal of the lateral incisor. We've already injection over molded the central. I used I used a DC 203 that was trimmed on the mesial. We're about to do the hips, so we can do delayed wedging. There's the aquarium. We're going to etch the entire tooth, rinse and dry. And then, of course, we're only going to put down just enough flowable to make a home for the wedge. And like Abdul Rahman said, don't extend the flowable all the way to the contact. It needs to be below the contact. That's a great visual, Ali. Thank you for teaching me something new today when I teach this. It needs to be below the contact for sure. Then we'll do delayed wedging. We'll put the wedges in. And here's the pre-op. And there's the post-op. And so the soft tissue response is always so beautiful around an infinity edge margin. You're not going to see this kind of gingival health around indirect. You just can't. That's a 10 micron margin. And on a young person, I mean, what a gift, right? What a gift. This shade was, they wanted white. This is white. This is not B1. So there's the immediate post-op. And there's the side-by-side view. So here she is pre-op. There she is post-op. So to answer your questions, I did all 6 teeth to be able to mitigate the space correctly. The space on the lateral the teeth were so small and the space was so large. And I told the orthodontist, give me an ideal arch form, make the occlusion perfect. I will close the spaces. I told the orthodontist, I don't care where you put the teeth, make it the strongest and the best arch form. And the orthodontist said, that's amazing, because normally they make him do crazy things with these teeth. I said, no, just put it in the middle of the space, make it strong, make it healthy. And it made things simpler. So it's kind of the opposite of what we used to do with these peg laterals. So this is interesting. This is a little GIF. The girl on the left is the twin that had the work done on Tuesday. And then the one on the right is about to go get in the chair and have her treatment done. So
Ah.
I'll just repeat. So
This is confusing.
yeah, it is. Yeah, it's kind of crazy, isn't it? You want to know a funny story, Abdul Rahman?
Yeah.
This is such an amazing video. Jeremy did the video and he lost it. He lost this video. And I wanted to, and then he found the video.
Yeah, this is a good video.
Okay, so here we are pre-op, and here we are post-operatively. And you know what's interesting is that the mother told me that because you know they're beautiful girls, people stop them in the street and they say, "My goodness, these two girls have the most beautiful smile that we've ever seen." And the twin on the left, they have this funny contest in America. She won the best smile in her whole school, in her high school. So for me, if she loves it, if it's strong and healthy, it can last for 20 years. And she won an award. She didn't get a smile design gauge, but she won an award of the best smile in her whole school. So the Beichler smile was the best smile voted on by all the kids. You know what? I care about the kids more than I care about some doctor who says blah, 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 right? And here they are, pre and post-op. Here's their 3-year follow-up. They're now 17. So here they are 3 years later, all grown up. And then here we just got a 7-year follow-up. So they were 14 at the time, and now they are 21. So
you didn't do any polishing?
What's that?
You didn't do any polishing?
No. I mean, they come in. They don't always get in on time for their cleanings, but we will touch it with the rock salt polisher for about 2 seconds, and that's it.
You don't need actually.
It depends on their habits and what kind of toothpaste they use, but they tend to not lose their shine. But I will hit it with the Rockstar polisher for 3 seconds when they come in for their prophylaxis. So the question is it strong? Is it healthy? Does the patient love it? And the answer is yes, yes, and yes.
This is amazing case, Dr. David.
Oh, thank you. I was so glad that the mom sent the pictures to me. So yeah, when you put composite into compression and it's monolithic, it can, I mean, if you have a 14-year-old girl, do you really want to put porcelain on a 14-year-old girl? As good as our ceramics are, they're going to wear out the opposing dentition. And so, especially for young patients, this is a great option. So let's hear from some of the doctors about my identical twin patients at 7 years later. They were 14 years old when they did it, and now they're 21.
What's the question again?
Do they have any questions about the twins?
Yeah, we have one question about how could you have the axial inclination? How can you control it?
How do you control the axial inclination? Well, the smile design gauge will help us once we've injection molded the case. The smile design gauge will help us once we've injection over molded the first tooth. We take it to 80%, and that smile design gauge can actually help you to determine if your inclinations and the size of the tooth are okay. And the other thing about the axial, this is a great question. The other thing about axial inclination is you have to be very careful when you put the hips in, because if the hip is off and you pull the matrix, don't pull it enough, then you'll have some other problems later. So the hips are important in angulation, and it's one of the things that I do is I rely very heavily on my photographs. I always photograph the case ahead of time, and I'll do some drawings on the paper, and then I have a very good idea. But the other thing that's helpful is the Beichler matrix, because of the shape, is your diagnostic wax up. So you really need to take a careful look at the inclination of the matrix, because the inclination of the matrix becomes the inclination of the tooth. So that's a great question. We're really over time here. So I want to wrap up here. And we're going to be answering people's question on the contest. I look forward to your emails. I want to put this slide up here very quickly. Oh. Give me just a minute here.
We have a repetitive question if you want to answer it.
Yes, let me get this screen up here for just a minute. So I want to answer the question in just a minute. I wanted to say something about my very dear friend, my brother, Abdul Rahman. You know, the world is getting to be a smaller place. I know that there's a lot of worries in the world, and one thing that I think that we've all thought about during this time is our family and friends. I think that we all are looking at our family and friends, and maybe hopefully looking at the most important thing in the world. And I'm so happy that I have my good friend and brother Abdul Rahman that I know is in spirit with me during this hard time. And we're very happy that we now have Dr. Abdul Rahman, who's been working on BioClear for at least 5 years. I think he's flown to the Learning Center, I think 4 or 5 times. So I'm so happy that he is part of our BioClear family, and we want to welcome you all into this great family. And I want to thank all of our visiting instructors who have given so much of their time to promote the BioClear method. And some of the folks are here on the screen, but there's 1,000 more doctors that are really giving and helping to do research and to teach others about the BioClear method. Dr. Ali?
Yes, thank you, Dr. David, for this kind of word, actually.
Why don't you, what I'd like to do, because it's getting, I think we're pretty far over time. Why don't we go ahead and have people email us these questions, and then we'll go in and answer them, and we can post them?
Yes, we can do that. And I can reply after we finish the live. I can go to the post and reply, because it will be there in the Facebook.
Because we have lots of comments.
Well,
he can also reply, Dr. David. He can do reply in the Facebook. He can do that, right?
Yeah, I mean, I'll tell you what. I mean, if people want to listen for another 5 minutes, should we do 5 minutes of Q&A here, or should we just wrap it up? Because it's been a long webinar.
It was like wealthy, so I like it. So, can you have 5 extra minutes, or
what's that?
Maybe 6. Why not?
All right, we'll do 5 more minutes of questions, and then what I promise you is that we'll do this again. The next one that we want to do is to do the modern class 2, injection molding, modern cavity preparation. So let's plan to do another one, but let's do it with the posterior.
Okay. Most welcome.
Okay, so let's go ahead and give us a couple of questions.
One question is about trimming. Everybody's asking about it. How and when to make the trimming?
Oh, the trimming of the matrix. Oh, yeah. Ali, why don't you answer that?
So can you set the question again, Vlad?
The trimming. When and how?
Yeah, first you have to try the matrix. So let's say if you have a space that may be confusing, it's not big, it's not small, and you want to go for the green matrix, the one with the more curvature. So first you have to try it. If you see that the emergence profile is starting above the gingival line, like supragingival, you have to push the matrix more apically. So you can say that why not using the less profile matrix, the pink one. So it may be not curved enough. So you have to train the matrix to decrease the profile, or we can say hide some of the profile of the green matrix subgingivally, so you can have gradual emergence profile. The thing is, if you trim too much, you might end up with the pink one. So you have to be careful how much you trim. So if you're not clever, or like you start to doing this kind of trimming, just trim less. And if you want to trim more, it's easy. But if you trim more than you need, you can't go back. You lose the matrix.
Very good. Yep. Now, the other reason we trim the matrix is if the patient has periodontal disease, then the matrix is just flat. Like on Charlie's case, that lady, she had 4 millimeter pockets. He did not trim the matrix to make a V cut. But you'll notice when I trimmed the matrix, I made an angle. And when I opened the matrix up, it had a V shape on the gingival. So if a patient has a very significant papilla, or they have a high zenith where the facial of the tooth is very high, we'll trim a V in the matrix just so that it will seat more fully, because we also trim for the papilla type of the patient. So some people have a very flat gum line. Other people have a very arcing gum line. So if the gum line arcs like this, then we'll trim a V notch in the matrix so that it seats more fully. And I showed you that when I trimmed. So if you want to watch how I trim the matrix, go back on the video. I folded the matrix over and trimmed it at about 35 degrees.
I think people are asking because your video was lagging in this special moment.
In this special moment. Okay, I don't think my video is up. Is my video up right now?
No.
It will be
microscope video.
Your video, yeah, it's up.
The microscope video.
Yes, that's it.
Well, let me show you. Let me show you how we trim that for a high papilla. Then. Are we live?
Yes.
Oh, perfect. Okay, there's my big finger. All right. So let's say that we were doing the mesial of this, and the matrix. This is a DC 201, and let's say that the patient had a very shallow pocket. Yeah, they begged me to keep going. Let's say they had a. Now I'm going to go ahead and sand the contact here. This is the other thing about when you have an existing contact, you have to sand and allow the matrix to seat. So I'm doing this as a true contact sander. I'm not opening the contact, I'm just lightening it. So let's say that we had an A101, or this is DC 201, and let's say that the patient had a 1 millimeter pocket. Okay, everybody can see that that is going to be a problem, isn't it? So if the patient had a 1 millimeter pocket right there, I've got to make some adjustments. So I'm going to take the matrix, I'm going to fold the matrix over, and I'm going to make a V cut, all about 35 degrees depending. I'm going to line the edges up. We've snipped it off, and voila. And like Dr. Abdurrahman was saying, we have less emergence profile now. So you can take a green matrix and trim a V notch. And now watch this. Let's say the patient had a 1 millimeter pocket. Look at how much deeper that the matrix seated. And have you also noticed that we have a lot less emergence profile now? So just like Ali was saying, if you take a green matrix and trim it, it acts more like a pink matrix. So I hope, Ali, can everyone see that? Is that a good demonstration?
Yes, it was very, very clear, yes.
Good. Now, here's the other thing. Now, I know we don't have the 360 veneer matrix yet in Egypt, but we hopefully will have it soon. On the 360 veneer matrix, this is a very wide matrix to add volume. But you'll notice on that, the V cut is already made for you. So that is a very deep cut for a very, very large papilla with a shallow pocket. And in a case like this, we don't trim it. Normally, we actually trim the flanges. So I would trim the palatal on this like that, which is actually easier to do. And then if I've trimmed the palatal, then it's not going to obstruct seating because the facial is usually much more recessed than the palatal. So that's how I would trim the 360 veneer matrix. So there's two different ways we trim. So hopefully we'll have the 360 veneer matrix soon in Egypt. You can see it's a very large matrix. It's for adding a lot of volume. For example, if for orthodontic crowding, if you want to tip the tooth buccally. So there's a couple different ways, but I thought that I would show you this 360 veneer matrix because it has a very aggressive cutout that we're able to create by cutting it also. So there you go. I'm glad that somebody asked that because we lost our video at that time, didn't we? So that's great. Okay, we've got a couple more minutes for questions.
I got, let's say, one last question.
Okay.
About the asthma closure steps and how to make it balanced if I have a big space.
Okay, I need to help you with this question, if I can, Dr. David. So if you have like a big diastema closure case, first we should know, are you talking about multiple diastema or one diastema? Because multiple diastema, it's like a huge case, like for the twin, it's kind of multiple diastema. So if you have only one diastema closure for, let's say, for a central incisor, first step, you have to see if you increase the width, does that will affect the length, the shape of the tooth. And also, if you have a chance, if the increasing the widths will affect the length, so you can get you can increase the length by adding volume to the incisor, or just remove some of the tissue from the cervical part, if you can do that. So to do quick smile design, you can do this. You can use the smile wheel. You have to look for the lateral excursion for the patient, because adding volume from the lingual, you might affect if the patient have some like over eruption for the lower teeth, because having diastema, you might have some over eruption for the two central incisor, so to the two lower central incisor. So it's kind of multidisciplinary thoughts only in two teeth. So if it's straightforward case, you can do it like in the same visit. But if it's quite complicated, like if for my case, for my friend Omar is that for I did it last year, I had to do some planning before to know how much I should remove from the lower teeth to correct the occlusion, how much should I remove from the distal for the central to correct the proportion of the two central at the end. So it is not as like a guideline to do it for every case. Just you have to know the end result. You can use this wax up if you want. You can use a smile wheel, like a fast wax up. Let's say it's a direct wax up for the patient.
I know that Pasquale Benuti, one thing that he does in Italy is he actually will slide a matrix in and just put a little flowable composite in and cure it, just not bonding it, to give the patient an idea of what it's going to look like.
An idea. It's so good also.
Yeah, I did that quite a bit, especially like for black triangles. People say, what's it going to look like? And I say, here, put the matrix in. You can slide it below the subgingivally without any pain. And I'll just take some cold flowable. I don't want it to go all the way to the lingual, and just put some in and cure it. Take the matrix off, and they say, okay, now I can see how it's going to look. And generally they are very excited because they get a picture of the big change. Because someone with big black triangles, it's going to have a new shape.
Yeah.
All right. Are we? Is that it, Ali?
Yes, I think we done for today. It was very good webinar, and sorry for like having you for such 3 hours, more than you have decided. But it was very rich webinar. I like it, and it's not easy to get to you in the Facebook. Thanks for coronavirus.
I think we can have a promise for another webinar for the posterior.
Yeah, he promised he will do that for the posterior teeth. Yeah.
We will do that. We will do that.
We'll manage it.
Yeah. And we'll even be a little more smooth on our end to make sure all the pictures are good. So I think we got it figured out.
One final important note, lots of people are asking, where are you represented in the Middle East? I mean, in which countries? You are in Egypt with Bibudent and in Iraq with Sensdent. Any other country?
I think Dr. David, he's not like knowing the dealers in the Middle East. Is it right? Jeremy, he will be responsible for that. So
As I know,
you asking the wrong person.
So in Egypt, with Bibudent,
one of the BioClear people told me that all they need to do is, if they will contact the BioClear Matrix, go to the BioClear website,
go to contact us,
go to contact us.
And at the very bottom.
At the very bottom.
There's a list of all the countries
There's a list of the countries. So that will tell you in it. And then you can always email. You can email BioClear. And if they don't answer you, I'll answer your emails. Okay. No, they always answer your emails. In case something ever gets lost, you can always email me. I'm happy to help everyone. So that hopefully that will answer that. Okay.
Thank you very much for your time and your effort.
All right.
Thank you, Dr. David.
Everybody have a great day. We love you out there, and we'll see you next time.
See you.
Yeah, stay safe. Stay safe.
Thank you. Thank you. For everybody who is watching us, please, we will send a link where you can fill your contact details so that we can send you the material of this webinar to your email. See you all. نشوفكم على خير ان شاء الله. بكره هيكون معانا دكتور محمد سعد، هنتكلم عن البايو اكتيف ماتيريالز. See you.